coming here. It's a pleasure to have so recognized faces, some new faces. We want to join with you this event from the Healthy Cloud project. What
So
our moment?
yeah, exactly. So thank you for the people joining today in person, but also online. So this is a public workshop of the Healthy Cloud project. We are going to give a super brief introduction. What is Healthy Cloud about? The context, why we are today here, and then we will have these two sessions. One with researcher with very interesting presentation and discussion, and also then the participation of the European Union.
So please, can you put the slides, guys? The first slide set. So it is the agenda for today, as Salva introduced the different slots. We will conduct through this agenda as seamless as possible. So just come on, just a quick introduction. This is something we need to do. We always want to do with our name. The name of the project is Healthy Cloud, and this don't refer to a cloud with good health. It's a cloud where we want to process health data. You know, the health data has its own particularities. It's a highly sensitive data that comes from multiple settings with their own particularities. And we know that having the possibility of working with this distributed computing approach, that means having computers distributed along different geographical situations, will help us, okay, to facilitate the management of this highly sensitive data. So the name of our project comes from health and cloud, because in Spanish the Y, the I, the E means and. Okay, so it's health and cloud. You can use Healthy Cloud. We use Healthy Cloud, but it's health and cloud.
Exactly.
So, well, about the consortium, this is one of the great things of this project. We co-coordinate, so something's difficult word, co-coordinate ourselves. Myself, I represent the Instituto Aragonés de Ciencias de la Salud, Institute for Health Sciences in Aragon. We are, let's say, in the charge of the domain, let's say the health side. Salva, co-coordinator.
Exactly. So, and then we are bringing the more computational oriented, the Barcelona Supercomputing Center. But what is important, we are not alone on this project, and it's endeavor. And we're bringing together many people from the domain. So,
yeah, for example, in the health domain, okay, we have this whole bunch of people representing academia, public health institutes, even health services from Spain, ourselves from Portugal ministry. So it's a huge part of the consortium devoted to the health side of the equation. And the other side?
The other side, we have EGI, we have CSC, we have Cloud, but still, the consortium is not complete without counting the research infrastructure. So do we have all of them here, where they are bringing really relevant expertise and also bringing potential solutions or the way to the services we will be talking about later on the how we can manage the services in the long term. Because this project is a project that will have a start, have an end, but we would like to see how we can serve the community in the long term.
Yeah. We always put this together, but at the very bottom, because they provide us the legal expertise, but they are, I mean, the TMF and University of Luxembourg. We send the last one because they're supporting us with the legal aspects, even that the legal efforts are also, the legal point of view expertise also distributed across the consortium. So this is the whole picture of the consortium. We know that it's a super strong consortium that will help us on our motivation, our objective, which is paving the way for an effective health research, health data related health. Oh, what's the saying?
Health related.
Health related data. I tend to say health data just for short. An effective health data sharing across Europe. Okay, and helping to conform the health data space by defining an strategic agenda, which will be the outcome of our project, and a strategy to set up the European Health Research and Innovation Cloud, what we short as the HRIC.
Exactly.
HRIC is the name of the final.
So actually, we have many components already there. we have many challenges already there, and this project is basically the final outcome, despite a number of deliverables and milestones. This is a strategic agenda with a number of elements, technical, but also a non-technical one. So providing the context, how we work, for instance, with the US Association, how we fit in the European health data space, and a number of other initiatives.
And well, this is why we call this is a well, you know, you come from this world. This is a broad and complex discussion. So we place here a lot of concepts. So regarding the fair data, discoverability. So those are the myriad of elements that we are putting on the mixer and shaking them to provide this at some point the strategic agenda that will cover all of them in a clear way and facilitating this future development of the HRIC.
Exactly. So, and then during today and this workshop, we will be touching on those keywords, but they are more than keywords. So they are realities. They represent challenges. They represent how to do things. So before this morning, we were discussing about fair data and semantic interoperability and a number of elements that we will be learning from the different speakers and also from the commission. We want to understand what are the views of the commission on the effort that we are putting today here.
Yeah. So the intention for today is aligning forces from the multiple stakeholders, as much voices as we can, okay, to progress in the work of the strategic agenda. We have an initial draft that we will present it in our third session, in our third slot of the of the workshop. We don't want to reinvent the wheel. Okay, this is something that we are have a completely agreement in the consortium. I guess all of the actors, all of the people involved here share with us. We don't want to reinvent the wheel. We need to stand on the shoulder of the giants. Probably this is a cliche, but it's a way to progress. Okay.
Actually, if you allow, sorry,
No, sorry.
if you allow me, rather than reinventing the wheel, we might need to realign the wheel, which is fine. But we should definitely avoid reinventing the wheel. There are many good elements there. We need to understand how we can put them together and then move forward.
Yeah. Faster and quicker. And well, the format is as presented by Salva previously. We will give voice to the experts from the community. We will give voice to the policymakers, the commission, and we will give you our propositions so far, and then discuss as much as possible, again, to distill, to improve our current version of the strategic agenda, to provide a final agenda which is completely agreed with the stakeholders, the communities, the policymakers, or giving the voice of as much stakeholders as possible. So,
If you, exactly, and if you allow me, Juan, we have 9 months to go to finish the project. So we are going to be basically what Juan was introducing, how to bring all these different perspectives in this final strategic agenda that is valuable to the community, that is actionable, that we can take decisions based on that. It's a big challenge, but we are going to do our best.
Okay, well, we are finishing here our introduction. This is the way we want to foster the on-site participation also, but as online participation, you're at home, you can go through Menti, introduce this code, and will help you to provide questions to our speakers. Okay, we are not allowing questions by chat. I think that the chat in the Teams is disabled, and use this tool to facilitate the exchange. So then let's go through to the speakers. Okay, this is the agenda again.
So thank you very much, Juan. So now I think you stay with me. We have the first part of the agenda. So we have the voice of researchers. So to make that possible, we have invited 3 different researchers with different perspectives, different responsibilities, and so on and so forth. And the plan is to talk about the research in the future health research and innovation cloud. What are the missing pieces? What are the views for our external stakeholders, and to understand what we haven't covered during the first part of the project. So to do that, we have 3 researchers. So we have Ricard Martinez. He is from the University of Valencia. He's the chair of the, let me get it right, the chair of the privacy and digital transformation cathedra. Oops. Okay. Then we have Maria Luisa Lavitrano. So she's one of the directors of the European Open Science Cloud. She's coming from Italy, from Bermarite, Italy. Very interesting projects there, and a physician. So that is really important. So we want people with hands-on experience. What are the challenges they are facing? And then we have Rosalind Paz. She's a data protection manager at the Belgian Cancer Registry. So as you see, we are bringing different experts with the complementary views. So we are going to be here for 1 hour approximately. The format is 20 minutes, 10 minutes presentations, 10-minute questions. But if we have time at the very end, we can also have a more broader discussion. So with that introduction, because we are a little bit late, so and I would like to go to the Ricard. Ricard, can you see us? Can you hear us?
Good morning. Could you hear me?
Yes.
Hello. Many thanks for your kind invitation. I try to be so synthetic. Let me say that I'm a constitutional law lecturer, but during my professional career, I work at the Data Protection Spanish Agency. I have been working on different conditions in order to assess university and research in university environments. And I collaborate a lot and in different situations regarding the developing of data analytics of app mobile applications and so on. Then I'm swearing different hats depending on the situation. What we have learned and in fact, part of my research has been to infer, to design how to process data in healthcare environments for research from GDPR to national laws. This experience comes in a previous moment from the European Health Data Space Regulation that, in my opinion, it's a really challenging law that probably must be adapted to different research needs during the proceeding. Let me say that our main difficulties in past in projects like big Medelytics regards about how to process anonymized data. And let me say that the conclusion, it's so convenient for the idea of the project. This is not only about the implementation of anonymization technique. Let me share with online a recently published article by MIT News. They conclude that there are no risks of re-identification if you complete your heart or a properly anonymization with additional guarantees regarding the environment. We are talking about security, we are talking about traceability, we are talking about registering, and we are talking about legal binding agreements. That's the solution that we implemented in Big Medelytics, that we are experimented in a Chameleon project, and the only way to provide intermediation services under Data Governance Act. It means, remember that we have to deal with a non-homogeneous regulatory landscape. If you remember, EHDS bets on anonymization, but it is possible to ask to the the organism with capability to authorize the access to data, the data access body, if you need to process pseudonymized data. But in this case, in my opinion, national laws applies. If you are working in Spain, national laws has been designed in order to permit to process pseudonymized data in a securized environment without any consent. But this is not the case of other countries. Then it is really relevant to define a general environment for processing data in healthcare research in this new regulation, because if we will come back to the general rules of GDPR, we will have the same problems. In fact, the way to solve these kind of problems have been to apply any kind of intermediation software in federated data spaces. We are talking about differential privacy, multi-party computation, and other tools, synthetic data, in order to provide the certainty that the ones who are processing data can't identify anyone. And really, this is so difficult to be implemented. But let me say that we need an additional layer of legal governance if we are operating as intermediation services as a cloud health research infrastructure. In this case, I think we have to differentiate between European Health Data Space, direct provision of services, or Data Governance Act. The reason is that in European Health Data Space, you could probably will required by the data access body in order to proportionate data. But in addition, you could be giving access to data users in your environment. To do that, in my opinion, you need a governance. You need to have permission proceedings. You need to have terms and conditions for data access users. You need to have a registering form and a registering procedure. And probably you need to nominate a data access committee, because we have to deal with ethics and legal compliance at 3 levels. We have to add to the traditional biomedical ethics, those who are the task of ethical committees, the AI ethics, the risk analysis that must be implemented in case of data analytics. This is not probably today compulsory under law, but this is strongly recommended in the last initiatives of the European Commission regarding healthcare research, and in my opinion, it will be compulsory under the new artificial intelligence regulation. Let me remember that this is a law based on risk analysis that qualifies any AI system considering the risks. And those systems that will process sensitive data will be considered for sure a high risk AI systems. It means that in terms of legal obligations and ethical obligations, the DPIA, the data protection impact assessment, the privacy by design tool, the audit of different controls you have to apply to AI in data protection, the risk analysis on anonymization, and finally, the risk analysis on how to proceed with the processing with AI tools will be so relevant. Let me give you a non-biomedical example. We are working in a project that processes data for small and medium enterprises. And there is a challenge regarding the recognition of fruit images in order to take decisions of commercializations. No personal data, no problems with GDPR. But if the system fails, the competence will have a problem, because there will be anybody taking decisions about distribution and causing harms to the farmers or to the market. And we have a risk analysis here on AI. If we are talking about medical devices, we are talking about inferences relevant for medical decisions and so on, it's clear that the ethical on AI requirements must be compulsory. Finally, you have to verify the legal compliance. Then remember, I underlined that anonymization, securized environment and trustable environment, and governance, in my opinion, must be compulsory. But there is a new and a fourth requirement really relevant: data altruism. Let me say that in my experience, the patients give us permission when they are ill. Usually, you said, okay, Mr. Martinez, you have the ill of Mr. Martinez. Could you collaborate in our research? From the point of view of data protection consent, we are accessing or we are achieving consent in an asymmetric situation. But if we want to promote data altruism, we have to consider any patient in any situation during a long period of time. It means that we have to promote pilots in order to verify how to obtain consent in a freely and unambiguous situation. And this means that probably we have to design strategies with different steps in order to inform, to confirm the information, and to giving consent. And let me share with you one lesson learned from the primary uses on European health data space regulation. They said, we will to empower the patient. We will to give them access and control over their data. In terms of data altruism for research activities, it must be the same. This is not only about an informed consent form. It's about the way we will be in touch constantly with the patient in order to inform him or her about the results, the use of their data, to confirm consents, to have a different report with them. And to finalize, with consent, we have an additional problem. Here in Spain, we regulate a wider concept of consent. Then here in Spain, you could consent for an area of research, not for a specific research or for a concrete or for a specific research of the project of a team. This is not the same in all over the countries, and this is not the approach of the data protection authorities. Then this must be clarified in the regulation in order to promote certainty to all of the research team in Europe. Because if we are betting on data altruism, we have to provide certainty and legal security. And that's all I want to share with you this morning.
Thank you very much, Ricard. So we have our initial question by Maria Luisa.
Thank you, Salva. Thank you, Ricardo, for this very interesting talk. I have a question for you. You said that anonymization should be, the choice should be compulsory. But then you said that for the informed consent, we need to go back to the patient for a long period of time. Now, with anonymization, the patient cannot exercise the right of withdrawal consent, of returning of results, of returning of the incidental findings. So, how you can manage with this? I think that pseudonymization is also good not only for researchers, of course, because to follow up with the patient, but also for the patient themselves.
I think at the end of the day, we will be completely agree. Let me differentiate between two or three scenarios. In case of anonymization, we have to deal with the different guidelines of national data protection authorities. You know, we have to deal with the opinion 5 from 2014 of the Working Party Article 29. Just right now, we talked in the EDPB, the European Data Protection Board. And let me say that they said in this opinion that to anonymize is really impossible. This is the conclusion of the opinion. You have to apply different strategies of anonymization. You have to guarantee not only the conditions of your anonymization, but the future in terms of next technologies, in terms of risk from anybody all over the world. Then this is really impossible to be achieved in practice. But you have to add that I remember that ICO, Information Commissioner of UK, have a guidelines. GNIL in France have a guidelines. Everybody in the European, the data protection agencies in Germany have a common guide, and in Spain we have our guide, and we recently republished the Singapore guide with a tool in order to anonymize. Then this is a very difficult effort. If you are processing data with consent in an anonymized way, the only information you could report to the patient regards the use of the dataset. In that case, you are not reporting him or her nothing about the data processing, nothing about the results. You only have to mark the dataset in order to send him or her information regarding, okay, we are so grateful, the dataset that that contains your data has been used in order to research cancer, blah, blah, blah. This is the only information you could have because you can't identify anybody in the dataset. The second possibility is pseudonymization. This is the choice of Spanish legislation due to the fact you said, if I use a pseudonymized data in a controlled environment, the final purpose of the law to protect patient data can be achieved. But I will have additional benefits. First of all, the dataset will be complete without any erasing, without any generalization, without any difficulty in order to process data. And second, in case of incidental finding, Spanish national law specifically states that the fact will be notified to those who have the identifier in order to protect the patient. There is a very really good combination. Let me say that in the Spanish case, it means that, okay, researchers and dataset, researchers cannot have access to any identifier. Second, the dataset is in a securized environment with a data protection impactment, with adequate security measures, with traceability, and so on. Third, it must be approved by the ethical committee. And fourth, there is compulsory to have binding agreements with the compromises of the researchers on non-re-identification. I think it's a really good solution, but this is not the solution of the EHDS proposal. This is not the solution of the GDPR. This is not the solution of a lot of national laws. But remember that if you read the recitals in the European Health Data Space proposal, they said, first choice, anonymization, but we have to recognize that under certain conditions, it's really difficult to work with anonymized data. In my opinion, it will be more usual than probably the lawmakers thought.
And what about anonymize the metadata? Yeah.
Let me say that this is a really relevant concern in the case of a Chameleon project, because we are dealing with cancer images, and we are identifying what metadata could re-identify the patient. This is not only about the content of the image, of the radiography, this is about the content of the metadata and the additional data that enrich the database. This is a really, really strong work to be implemented. And we are, just right now, we are discussing these days about our methodology, its correction, and implementing a risk analysis in order to be sure that all of identifier have been erased. Let me say that this means that we are applying 2 layers of anonymization. Usually, in hospital environments, they are talking about anonymization when they really are talking about the identification. In all of my projects, when you receive the database from the hospital, we have implemented a second layer of anonymization. We need to be sure that data has been duly anonymized. If not, you could be in a hurry. It's relevant, really relevant to do that. And you are completely right. You have to consider metadata as part of your work.
Perfect. Thank you. We have a question from the audience.
Hello, my name is Mihaela Matei. I work for ECRIN. I would like to go back to Maria Luisa question, the previous one. I think Maria Luisa, correct me if I'm wrong, you just raised a ethical question, not a legal question. Because in case of anonymization, assuming that we can anonymize the data, we don't fall under the GDPR anymore. But the question is, do we choose this solution, meaning anonymization, considering that in case of anonymization, we cannot go to the patient, back to the patients anymore. We cannot inform them about incidental findings, and people cannot withdraw anymore. So I think it's not a legal solution, but I would say that's a ethical position or ethical perspective and choice that should be made by the data controller and then by the researcher as well. It depends on should we anonymize or not the data. So this is the question. So I understand that anonymization might solve many legal issues, but the question is how do we address the ethical issues in case we cannot go back to patients to inform them about the incidental findings.
Yeah, I completely agree with you, but this is not only an ethical issue, this is a legal issue too. Let me say that, in my opinion, we had, especially during COVID, a problem with privacy experts, with privacy champions, and with data protection authorities. Let me say that when I teach constitutional law at my university, there is an article in Spain regarding to right of everybody to life. This is a constitutional right. In fact, if you are not alive, if you are dead, you have no rights. This is so simply to be understood. And in every constitution, in the European Charter of Human Rights or Fundamental Rights, this is so clear. And we are promoting quality of life, recovery, and in this case of research activity, we are helping the healthcare system in order to provide healthcare services. Then this is not only a legal issue, an ethical issue. If we are talking about life, we are talking about illness, if we are talking about vulnerable persons that are suffering, in my opinion, there is no choice. We have to re-identify, we have to promote the recovery of the patient, or we have to prevent any incidental damage. And if we talk only with data protection authority about that, it seems so stupid, but I absolutely confused because I think that they have not understood this. It's really sad to say to anybody, I am so sorry, your wife is dead, but we granted her data protection right till the end. This is stupid. This is not. This is ethically unbelievable. That's the reason I thought and I said that we have to change our approach and we have to learn, for example, from Spanish regulation in order to promote this kind of identification, this kind of uses where it will be needed.
Can I answer this? Yeah.
Yeah, very shortly.
Yeah, it's very short. So I fully agree with you. Actually, from a legal perspective, my issue was during the COVID pandemic is the fact that there is no specific legal provision or legal framework for this type of situation. So, for instance, in France, so as you nicely explained, so we have to take into account several legal layers. The one of them is in relation to the GDPR, but there is another one that we are applying in the context of clinical research is the qualification of health research protocol. So we can fall under the clinical trial regulation or under other type of regulations depending on the national system. So the problem with the research on COVID is that we couldn't properly, we didn't have a framework or a specific category of research that allows us to perform rapidly this type of clinical trials or research, health-related research, because it's not always a clinical trial. So, for instance, in France, in order to qualify this type of research, we had to use the provisions applicable to emergency research situation, which is not always the case because some of the patients in the context of COVID were able to give consent. So yeah, so legally speaking, one of the issues that we have, and maybe it's also in relation to the GDPR, is the fact that there are no specific provisions for research in the context of pandemics. So this is another issue.
Let me give you an example. In Spain, our health public system processed a lot of anonymous data, but we have a specific provision that permits to process personal data without any consent for public health purposes during a pandemic situation. This is expressly stated by public opinion, data protection agencies' positions, and so on, in practice, affect the decisions of the healthcare public system. This is not correct. We are not in a correct way. And let me say, in addition, other issue. If you remember, the European Data Protection Board said that there were no possibility to process telephone numbers in order to communicate with patients, in order to obtain geolocation of patients. Then, I remember in April 2020, I was traveling in a bus in my city with 70 persons that I never met or known with a positive COVID disease. How could I share with the person who are making a contact tracing about the people I'm contacted with? This is impossible, but the telephone company needs only 1 minute to do that. And this data have been sent, if possible, directly to the health record of the patient. And in this case, the practitioner could talk directly with vulnerable persons in order to prevent and to help them. But this was forbidden by GDPR and by the European Data Protection Authority. And let me be really clear. They killed persons. I know that this is so rigorous, but in my opinion, this was the result.
Oh, so I would like to finalize your intervention, Ricard, with a more positive tone. So I will come back later, if possible, about data altruism. But by now, thank you very much for the intervention. It has been super interesting, and it's a pity you are not here with us, because probably coffee would have been great to keep discussing.
Juan, let me add only one thing. I'm so contundent because I need to transmit to the authorities the real needs of researchers. I think, like me and my colleagues of the panel, understand that we are working for a common good, that we are working for research. We are not the ones who decide, we are ones who are serving and promoting the common good of our societies. Then we need to impulse the knowledge of the data of the lawmakers in order to understand how to conceive, how to balance privacy rights and research activities. And this is possible if you have an open mind. But to have an open mind, you need to know the consequences. You need to know that there will be people who could be suffering or who could be dying. And I need to be clear with that. I hate really this negative approach, but it's really relevant to communicate this fact. We are working for patient, for a vulnerable and suffering person. And in my approach to data protection will serve human beings and not the contrary.
fully agree with your views, and I wouldn't say negative. I will say realistic. And with
Yeah.
that tone, with that tone, I would like to invite Maria Luisa to the stage for her presentation. Thank you very much.
Okay, so thank you. Good morning. Thank you for the invitation. Always a pleasure to be with you, and especially today to talk this about these very interesting issues. So my talk will be just to setting the scene. I will talk about the science in transition and the open science and EOSC that are European priorities. But really, Salva asked me to talk about challenges to systematically use health-related data for research and what opportunities we have at the moment to solve these challenges and what EOSC can do. So, European priorities. Science is in transition. The open science paradigm affects the whole research cycle and all its stakeholders, and implies the knowledge to sharing knowledge and tools as early as possible, as openly as possible, as restricted as necessary, as we say always, as fair as possible, developing and enabling policies. Now, the open science is a political priority for Union, and the member states' commitment for the ERA action clearly identified either the open science and EOSC and research infrastructure as a priority. And we have to take this in mind. So now, going to the challenges. Challenges. Several challenges have already been discussed. The challenges are related to data, are related to the management of data, and the access to data, to infrastructure, and to policies. So the first challenge is about interoperability of health-related data. There is actually the need of set of standards and guidelines to support interoperability. And really, we are not there yet. Then we already discussed about the balance between the application of the FAIR principles, so to access data, to have data accessible and reusable, findable, accessible and reusable, to balance this with the protection of privacy and promoting the safe use of citizens' health data. So now we discuss already this. Then infrastructure. There is the need to develop a technical computational infrastructure that needs to be certified and also GDPR compatible. Another topic is the security, already discussed. So a lot have been discussed already. The health data processed and stored in secure system need to have a security management system. And this is the condition to have the trust of the patient and the citizens. About legal guidance, we really need a legal guidance. We need to have harmonized legal basis for access and use of data. We discussed already this. The GDPR, I mean, have a fragmented interpretation across Europe. I think that there is the need for clarity about this, and also I think that we don't need another regulation. We need to clarify the regulation that is already in place. Very important is training for actual and new generation of data managers and also of clinicians. We need to learn how to manage data and how to make fair by design the data from, the health system. And the last actually comment, we discuss about artificial intelligence. I want to point out that artificial intelligence can raise ethical concern, discrimination, because, very often the data set, do not include data, that includes gender and minorities, and so on. And so this type of um, are underrepresented usually in the data set. And therefore, since artificial intelligence needs to be trained, I mean, for doing artificial intelligence, there is the need for to train the data set. So there could be, the risk of really a discrimination. And we need to discuss about this. Now, what opportunities we have at the moment to address those challenges and what EOSC elements can be utilized. What is EOSC? We all know what is EOSC. It's a web of scientific insights, web of fair data and related services. So everything is in EOSC apparently. Federation of relevant existing and future data sources, federation of the e-infra and research infrastructure, is a virtual space where science producers and consumers come together, is the environment in which data can be brought together with services to perform analysis and address societal challenges. Now, EOSC, can be seen as a cross-cutting data infrastructure focused on research and innovation that intersect all sectorial data spaces. And the development of the European health data space should avoid that data guidelines and management of health fair data, I'm reading, may grow because this was, agreed, may grow apart with the risk of lessening the impact on research and overall European data strategy. So this is very important. We really don't need to reinvent the wheel, as Salva said at the beginning. And the existence of EOSC initiatives should be pointed out in all sectoral data space initiatives, in their regulations and communication, as a fundamental source of synergies with the overall European effort towards coherent overarching strategy, and therefore also avoiding parallel and unconnected development. This is very important. In the actual text of the regulation of the health data space, EOSC is mentioned only once. And this is also in the interest of the EU member states and the investment at the national and European level to maximize the impact as well as to avoid underspending. So the European health data space should really develop synergistically with the EOSC initiative, exploiting and strengthening the relevant existing public infrastructure and services, and should in general build on and make use of already existing infrastructure and fair data services that are already existing and developing in the different project of EOSC project. In addition to that, the European Health Data Space Board shall cooperate with all the other relevant bodies, entities and experts, including EOSC of course, in the effort of reaching advanced solution for the fair data usage in research and innovation. And the health data access bodies shall cooperate with the governance of EOSC to build upon the experience in building a European fair data space and to elaborate with the research effort towards an interoperability solution in the frame of EOSC. It's very important that the implementation of new infrastructure for the secondary use of electronic health data will be done in coherence with the overall IT governance framework of the European Commission, especially building upon the expertise and technical solution developed in the field of research and innovation, and therefore contributing to the strengthening of the EU effort for a coherent fair data policy. The purpose of the EOSC association that I'm representing here today is actually to provide what we say the single voice for the advocacy and representation of the broader EOSC stakeholder community. So the EOSC association represents all of us: research performing organization, service provider organization, research funding organization. And the purpose is to promote the alignment of the European Union research policies and priorities with activities coordinated by the association. There is really the need of coordination. We see there are lots of projects, lots of initiatives, lots of tools and infrastructure, and we need to really to coordinate all these product and tools and initiatives. And also, of course, to enable seamless access to data through interoperable services that address the entire research data life cycle. This is the association today. This picture has been taken during the General Assembly in May. The association have a strong member base with 163 members at the moment and 78 observers, including research performing organizations, service providers organization, and funding bodies. And also, we have a very large EOSC brain pool with over 400 volunteers that contributed to the development of to the work of task forces. Here you see 5 groups, including 13 task forces working for the development of the strategic agenda and the EOSC. And I want to focus only on the task force very briefly. I mean, I will not go into details that are related to data. The task force on metadata and data quality with the FAIR metrics and data quality task force for the implement and of the proposed FAIR metrics for EOSC by assessing their applicability across research communities and testing a range of tools to enable the uptake. The semantic interoperability of task force, this is very important for reaching the interoperability. The data stewardship curricula and career path. The long-term data preservation task force, this is also very important to think about long-term preservation of data. And lastly, the technical interoperability of data and services task force. Data interoperability is very important, and interoperability have several layers. The legal interoperability, that is about the copyright, the licensing, the data protection, and the GDPR. And there is the need for an alignment across Europe on this. The organizational interoperability that are related to rules of participation, long-term funding plans for services, responsibility for providing services, the semantic interoperability related to metadata and ontologies, interpretation of meanings and structure, and lastly, the technical interoperability that is related to the framework, authorization, and authentication infrastructure providers, PDI, and persistent identifier. Lastly, I want to say that, to my point of view, the division between primary use and secondary use of health data cannot be strictly upheld in practice. The research is at the basis of an efficient healthcare, and in turn, healthcare can offer challenges path to research. So to my point of view, healthcare system should be set up from the start in a compatible way with the needs of research. Health data and digital workflow are at the intersection of primary care and research and need to be conceptualized from the beginning as complementary to reduce errors, avoid duplication of procedures, and allow for innovative digital health solution. And in Italy, we have a pilot project. We have a project on biobanking, the healthcare integrated biobanking, but also we have a pilot project on FAIR by design. This is in Bologna. There are the university, the research hospitals, 3 research hospitals, and several other hospitals, in which actually they collect and access large volumes of data in compliance with legal, organizational, and regulatory requirements. And the input data source undergo an assessment process to establish their origin, permitted uses, presence of valid consent and authorization, and condition for processing. Outcomes of this assessment process are coded into a set of standardized metadata. And this Alma Health database will support data fairness with dedicated services for data curation, data quality management, analysis of legal requirements, and standardization of data and metadata. This is not so difficult for data collected prospectively, but we are also working for data already collected, so for retrospective work. So this will come later. And with this, I thank you very much, and available for question.
Thank you very much, Maria Luisa. Questions from the audience?
Christian Oman from ECRIN. You talked about cooperation between EHDS and EOSC in the area of research and innovation. How do you want to do that? What is the plan? Is there formal things foreseen, working groups, structures, or is it more an informal process? What is the plan for that?
We need to start a dialogue. Let's say like this. We need to start a dialogue. For sure, on the side of the Commission, at least in the framework of project, the health data space is always mentioned in the previous one and also in the next one, has, very important for when the development, of the project. And I think that the same should be, about vice versa on health data space. So we really need to dialogue. We don't need to not only to reinvent the wheel, but we already have services that are developed or are developing, and we have infrastructure with the expertise for, providing support to the aims of the health data space. So I think that at some point the intersection will happen, hopefully.
Thank you very much. He stole my question, by the way. Klaus.
I mean, it's a lot of really good points to pick up on, Maria Luisa. I wanted to pick up on one, which I agree I think is one of the major challenges. In this federated landscape, you talked about people and training about people, but I think one of the major challenges we have is to make sure that we build up capacity and skills in all the national facilities that will have to manage data and manage access to data at a completely different scale. So it's not only the technical skills, but also the sort of organizational and management skills required to work in that large European network. I don't know if you have any thoughts on that.
Indeed. Thank you for the question. This gives me the possibility to introduce a number of projects that are already funded and that are working towards this aim. What really is needed is to provide skills, to empower the new generations, and also to pave the way for the new generations of data managers, data stewards, and also to the clinicians. Actually, we need to be empowered and to learn how to manage data and how to generate already fair by design data during the clinical practice. And we think that this should be done in a coordinated way at the European level. If the training is done in a fractionated way, like is done at the moment, we will go nowhere. If in any project 100,000, 200,000 of euros will be devoted to training, what we can do, organize workshop, trying to, but not really a complete program for training, for the actual data managers, actual scientists, but also for the next. So we need really to have at the European level a coordination of these activities. And there are projects like Skill for EOSC or Writing Plus.
Thank you very much. There is any other question, Sandra?
Thank you very much, Maria Luisa, for your presentation. I only have a question. It's kind of, I would really like to have some insight on the thoughts from within the association regarding EOS Health, which, might be a specificity within it. I think the reasons behind this specificity has been argued elsewhere and broadly, but it's still unclear to me, what are the thoughts from within the association? Because I think you're right. You claim that representing researchers and the broad set of researchers in health is definitely an aim, but I wonder to what extent that's a reality in the current status. So if you could shed some light on the thoughts on how you intend to achieve that and to actually have a news health. Thank you so much.
Um, as you know, the association is still, I cannot say a newborn, but still an infant, right? So we started to work launching a number of task forces on, general issues. But we are well aware that are specific domains where we have to focus more. And one of the first initiative that we have, and starting this initiative, is to work with and to launch a working group with research infrastructure of any domain, including health, and start discussing with the infrastructure what to do together to better implement and exploit the services for IOSC. And for sure, in the next future, very soon, we also will focus more on specific domains.
Thank you very much. Sandra, I don't know if you want to follow up the question. Okay. Very last question. Um, you were advocating for clarity in the regulation, right? That we have regulation, should be clarity how we operate in that framework. But you also were advocating about this artificial division of primary use of data and secondary use of data. To me, and I would like to know your thoughts, primary use of data has their own regulation. So removing that barrier maybe will complicate the whole context rather than simplifying it. What do you think?
I'm not talking about removing barriers. What I want to say is that the data from the health system, the data generated from the health system should really be kind of organized, generated already according to the FAIR principles in a way that they can be immediately useful for research, right? Because to make data fair ex post cost money, cost a lot of effort, and therefore, there is really the need to think about fair by design collection of data, also in the clinical practice. And this requires a change of culture and some tools and infrastructure.
And probably some money as well.
And some money, of course. And some money.
Okay.
There are, I'm sorry. YouTube live streaming is not working, huh?
Okay. We have switched to Microsoft Teams.
As the IOSC Association currently involved the health-related communities, public health institutes, healthy experts, is there room for improvement, the involvement? Yes, we encourage the involvement of and to enlarge our community, and we are lucky enough to have several infrastructure, and in the infrastructure, and there are experts on ELSI, on legal experts, and also ELSI ethical experts that are part of our task forces and are helping in shaping this our work. And there are other organized communities acting as an IOSC data space.
That is probably the answer is can be discussed over coffee.
Yeah.
Okay. Perfect. So thank you very much, Maria Luisa. So and then we move to our next speaker. So Roslyn, let me see whether I can pronounce properly. So Roslyn Paz. So you're, she's coming from the data protection. Oh, she works as a data protection manager at the Belgian Cancer Registry. So welcome, please.
Thank you. Hello, everyone. Thanks for inviting me to speak today. I want to make sure that everyone knows that I'm not a lawyer, so I'm not an expert in GDPR and in all of those laws. The first speaker was, if I'm correct. So for all those questions, you can go to him. I work closely together with our DPO, so I'm also not a DPO officer, so a data protection officer. I have an experience in data, like in science. I did a PhD, and I'm now working for the Belgian Cancer Registry. And I will talk on sensitive data sharing for research, specific for our organization, and the challenges we have as a data holder. So, who are we? What do we do? We are actually a foundation of public utility. We collect all data on new cancer diagnoses and their follow-up. And we actually set up a Belgian cancer database in order to report on incidence, prevalence, and survival of different cancer types, to evaluate cancer screening programs that are currently running in Belgium, to evaluate cancer treatment. And also a big task we do is to perform just certain studies on cancer. And a lot of those studies are really performed by our internal research department, but we also want to make it possible for external researchers to use the data we collect. And so this is where the data sharing pops up and all the questions around it. For us, the legislation we have to keep in mind are the General Data Protection Regulation, the specific law that mentions our organization, the things we can do, the data we can collect, the transfers we can make to perform our legal tasks. And then last but not least, we also have to look at a law of December 13th. It was set up in 2006. And it's about actually the establishing the Information Security Committee. I'm so sorry. So this is an organization in Belgium. It's very specific. I don't know who already heard of them. But the most important thing they do, if you want to link certain sensitive data, health data, social, about certain social topics, social economical status, you have to ask authorization in Belgium to do that. And so that's the organization that can provide you with an authorization. We see in our organization two different types of data sharing, or two different options. And I will try to make this as practical as possible. So imagine a certain researcher comes to our organization and asks, or like wants to perform a real life study on the epidemiology and choice of treatment for patients with follicular non-Hodgkin lymphoma in Belgium. That student or that researcher needs actually data that is available at our organization. They don't need additional data linkage with experimental data that is being collected. They don't need additional data from another data holder, just from our organization. In that case, we see the best option to give this researcher access on our remote environment. It's a secured environment. We can talk about, like, we are providing a VPN access, they can access the data. All the things that we have to accomplish to make this possible. Step one, make sure there is a research agreement. This research agreement can be seen as actually a transfer agreement in line of the GDPR. We have certain aspects that are part of that agreement. We make sure that there is a purpose limitation. The researcher cannot use the data that are made available on our remote environment for different projects, just for this project. There is an overview of all the variables that are being requested. We make sure that there are not variables being requested that are needed, that are not needed to answer the research question. We ask specifically not to try to re-identify the data subjects that are involved in the data base. We make sure that the researcher is not sharing the data with other partners or other parties. The researcher needs to sign a confidentiality agreement, and they can only publish sufficiently aggregated data. And they can only publish those data after we've seen the certain analysis, and if we think that they are sufficiently aggregated. Step 2, we provide the researcher with a privacy awareness training, and actually also a meeting afterwards to make sure that they know what they can do, what they can't do on our remote environment. Step 3 is actually providing the VPN access and everything that comes with that. And actually, after step 3, the researcher is having access to their data. The challenges we have with this option, it's very time consuming. So the process from the beginning until the actual data access, it takes a long time. The procedure is very long. We need to make sure that there is a training, that the researcher can follow the training. They are very busy because often they are also doctors. They are having a very busy schedule. We need to provide guidance with adherence to the procedure. We need to make sure that actually everything we ask for is very good followed, because we're a data controller in this view, and we need to make sure that all the data protection rules are followed, and we need to follow up on the agreements. And so it's actually very obvious that all of this leads into very high costs for us in human resources. Costs that are hard, I mean, funding that is often hard to find. So yeah. Then there is an option 2. A researcher comes to our organization and wants to perform a study to investigate the association between early in-life exposures to ionizing radiation and risk of cancer. Very nice research question. In this case, the researcher has its own experimental data, wants to use also health insurance data, and wants to use our data. So 3 different data holders. And more specifically, the researcher wants to perform the data analysis on their own data warehouse because they want to actually also have data from other European countries. They want to bring the data together, and then they want to research everything together. So it's not an option to provide the data or provide access to our secured environment. The data has to be transferred. And this is actually our second option, the data transfer. What needs to be done if you want to really transfer the data? First of all, there is the organization that I talked about. There's the Information Security Committee, and they need to give, or they need to provide, an approval. To get such approval, you need to submit an approval form with a lot of information, data protection info of all the data holders or providers involved, contact info, information about their DPO, whether there is a supervising physician available or not. All of those organizations, their lawful basis for the data processing, the applicable legislation, technical and organizational measures, and so on. So a lot of information from all the different data holders. They want also a very specific list of all the data variables that are being requested to link with each other. They want to have a description of those variables. What do they mean? They want also a reason why those variables are being requested. They want to see a data flow. Where is the data starting? Where is it going to? Where is the endpoint of the data? They want to make sure that there is a trusted third party involved that is able to link the data to code the data actually. So we are having non-pseudonymized data, but in the end, the researcher will be working with pseudonymized data. And so there is this independent organization called a trusted third party here in Belgium that is actually linking those data, coding them, and so on. And then they also asked to perform a theoretical small cell risk analysis. I don't know whether all of you already heard of it. If you have questions about that, we can talk about that in the discussion. And then last but not least, they also ask to perform data protection impact assessment and to make sure that that there are certain agreements between the data holders involved. Step 2 is a data transfer agreement, because we are sending our data to another organization, we are sending them out. We want to make sure that there is a data transfer agreement in place for doing that. And that data transfer agreement is actually, I'm not going to go through them again, it's actually having a lot of aspects that I already talked about in the research agreement. It's quite similar, a lot of things come back there. And then we have step 3, it's actually preparing the data, making sure that the right data are being selected and actually transferring them. The challenges that are involved here is, first of all, it's again very time consuming. You need to make sure that this application form is being submitted at the Information Security Committee. The approval form is actually only existing in Dutch or French. So international researchers are having like a lot of problems submitting this form because it's not existing in English. The organization is having a very strict approach on the GDPR, so that's also a challenge. After you actually submit your form, there are often a lot of changes asked to be made, so it's a long process for until approval. And we actually don't know whether what their standpoint is today when it comes to international studies that are being performed. This was it. Are there any questions?
Thank you very much. Questions from the audience? Yep, there is one in the back.
Thank you for the presentation. I have rather a legalistic question. So when you establish all these agreements, are you establishing them with a researcher as a natural person? Because I assume that they don't represent, okay, with their organization.
Always with an institution.
Okay.
Yeah. Never with a personal, because it's impossible for that person to really stand in for if things go wrong, etc.
So absolutely.
Always the institution. But that's also where there is a big hassle, because researchers often change affiliations. So they start their project, then the project is running. It takes sometimes up to 4 years until the project is actually done. They change affiliations, but then you're having this issue because the agreement is being established with the first affiliation, but the research is actually still going on while they already changed affiliations. So it's hard.
Okay. So in terms of responsibility, role and responsibility, I assume the researchers organization will act as a data processor, right? Or data controller.
Data control. We see it actually as when we transfer our data, we see it actually as a transfer between two data controllers.
Okay. Yeah. But we don't share the responsibility, right? So it's not a joint controllership.
No.
Okay. And the next,
but again, I must say, like, I think this is also maybe one of the challenges. It's like we do the best as we can because we want to make it possible to share our data.
Absolutely.
We see it as our duty, actually, as an organization holding so much important data. But I mean, this might not be the correct way to proceed. So it would be nice to have some guidance.
It's a matter of also of taking the risk, right? So what kind
Exactly.
of level of risk your organization wants to
Is
assume?
willing to take.
Yeah, exactly. And the last question would be: do you request a insurance coverage? And what type do you? Is it a professional insurance coverage? Is it a specific cyber?
You have
insurance?
specific insurances that are like taking the data protection aspect also in there. Um, a lot. I'm not an insurance expert, but I know that they exist. So it's something definitely to look into.
Okay, but is it required by agreement or?
No, it's not. It's not
Okay.
required
Okay,
so far.
thank you.
Thank you very much. Okay, there is another question.
Hello, Irene from Cinsano.
Hello.
Thank you very much for presenting nicely the challenges of the researchers. Now I wanted to ask you, what solution do you think would fasten up this process and improve it? Do you see these solutions at the moment in the legislation for the European health data space? And what are the services that are still missing?
Well, I think it's quite hard. So the GDPR was there to make sure that data sharing would be easier amongst countries between the EU. But because there are still a lot of like national legislations that are still there, it's quite hard. So I think we need to go towards a real like common view on the regulation um, on how we interpret GDPR, and I think that would be a solution somewhere. Um, make sure that we're talking about the same things. Is that an answer to your question?
Okay, I see Nicholas there.
Thank you. Thank you. I really enjoyed the talk. Now, it struck me we often make catalogs and discuss in these European projects about the challenges, but I don't think I've ever seen a catalog of organizations that do this in practice and list potential solutions. And I think that sort of playbook of things that are already working would be very, very useful. So that might be something to pick up in the context of HealthyCloud.
Thank you. No, that is great. Actually, in line with what Nicholas was saying, imagine for a second that you can scale up the process. Which services will be essential to you to do it? So, because human resources was a limiting factor, uh, um, so what would you need?
I think for us, as a cancer registry, so amongst Europe, there are a lot of different cancer registries, like every country has their own. I think it would be very nice to talk together about this issue, to have like a certain working group to see how they are working around this topic, to maybe like find a common ground. Uh, I think that would be very helpful right now for us. But then there is also it's also important to be able to link data related to cancer to other data. So then there is this other issue. So we cannot just restrict ourselves through like the cancer registries, but we need to go beyond and further. But I think bringing together organizations is a very good start.
Okay, so that will be like a community of practice to bring different cancer registries. And then in my mind, when you're saying the possibility to link different data types resemble fair data, because if you have this interoperability aspect, then you can start looking for ways to interoperate and then to go
Yeah.
beyond the cancer
Yeah.
registry data. Okay. So we will invite you actually to the year for cancer that has been mentioned in the question that we have here in the screen. That because of time, we are not going to go into that, just to elaborate a little bit further. Thank you very much.
Okay, thank you.
And thank you to all the speakers on this session. Oh, sorry, Maria Luisa.
No. I mean, I just wanted to point out that it's very important for cancer registries also to have links with other type of data, like environmental data
Sure.
and socioeconomic data. And also, what is very, very important is the interoperability between cancer registries. I mean, to have semantic interoperability, which is not true in Europe, at least not for all the cancer registries. So and we need to work together on this.
Exactly. So
Yeah.
word taken to both of you. Okay, thank you very much. Thank you
you
to all the
all.
speakers. And then we move to the next session. Then
Let me welcome to the second session. Thank you. There is a common thought here. Is the session the Commission already started? No, it's about to start. May I ask Christina and Jerome, please? I'm going to share you. I guess we do have Sila already online. Should be there. Christina, you are staying there for a moment? So can be when you're ready. So we are running 25 minutes. So the chair hasn't chaired, actually. I'm going to share myself. So we do have, hope you agree with me. Could you tell me if Sila is online already? She is? Okay. So high expectations about this panel, I guess. Jerome, Christina, and Sila. We're working hard to make possible, provide some solutions to the debate that we're having these days here, and you are sharing here and there all the time, in and out, talking about the same things. So this is basic because this panel has raised so many expectations. People asking, for example, if it has started already or not. So we are having 3 presentations, 10 minutes each. I would suggest just having the round of comments, suggestion, thinking, or questions for them at the end, so we can maybe wrap up instead of going one after the other. And I think we can start with Jerome. Jerome Barros, actually, for those that you don't know, is a policy officer at the DG Santé, Digital Health. It's quite involved in the development of the European health data space for secondary use. So Jerome, please, the floor is yours.
Thank you, Enrique. And thank you for the invitation and give us the opportunity to present the European Health Data Space. So, I don't know about the slides.
Slides for Jerome? You can stand back here, I think. That's convenient for you.
So good morning, everyone. So 10 minutes, I'll try to be as brief as I can on the European data space and what we are proposing for the use and reuse of health data. So if you move to the next slide. Oh, I do it myself. Forgive me. So first, just a brief overview of what actually are we proposing with the European health data space. As you can see here, it is a regulation. And what it proposes are a set of rules. This is what we have included in the legal proposals, but also common standards, a governance, a framework for the reuse, the use and the use of health data for care, but also for research, innovation, policy making, and regulatory purposes. And what it aims to achieve is those 3 objectives that you see underneath. The first one is to empower individuals to not only have access to their data, but also control it. 2, we really want to create this single market for digital solutions, so for digital product services. And in particular, we're legislating a lot on the electronic health record systems. And finally, and perhaps the most relevant for today, is we are creating a consistent framework for the use of health data for the secondary use that I mentioned here, so research, innovation, policy making, and regulatory purposes. So in practice, this is what we are aiming to propose. So the overall objective would be this effectiveness of health data. That's what ultimately ought to be achieved. And for this purpose, we do have 2 main, the scope is just said, the scope around first the primary use of health data, the use of data for care. And for this, some of the provisions that the key provisions that we are proposing are first empowering the various contact data. What do we mean by that? What we're saying here is that patients should not only have access to their data, they should also control it. By this, we mean being able to share this data with healthcare professionals of their choice, editing this data if it is not currently inputted, if information is missing, and importantly as well, restricting access to this data or part of it if it is their choice. So this is what we really view as empowering patients. We also have a set of articles on the standardizations and mandatory certification of electronic health records systems, obviously one of the key resources when it comes to health data. We also have an article looking at the voluntary labeling of wellness app. This is obviously not an emerging field, but a field that is growing and that probably requires some structuring, which is why we propose this labeling of those apps. And finally, we are promoting the electronic health record exchange format because it's the one underpinning the My Health ITU platform, so the platform that is being used for primary use already. When it comes to secondary use, the one of the key initiatives that we are proposing is the establishment of health data access bodies. They would be national health data agencies responsible to provide this access, to facilitate this access to health data for the purposes I mentioned before. Finally, we are defining a set of purposes for which this data will be made available. It wouldn't be made available for the sake of it. The idea is really that through those purposes, benefiting individuals. We're also setting a series of forbidden purposes, that is, purposes for which data would never be made available, and think of anything that would be detrimental to individuals. Finally, we're also setting a framework for making this data available. So we are proposing data permits. View this almost as a contract that determines what data will be made available, who would have access to this data, where, for how long. The idea is really to formalize this access. And these data would only be made available in secure environments. This is something, as you've seen, is widely promoted and adopted by several initiatives, but it's something we really want to really put in the law to make sure that data is only provided in a secured way. And finally, when it comes to no identification, that is, data that would be made available is either anonymized or pseudonymized, and only anonymized data could be extracted from this secure environment. So this is all the different aspects when it comes to the legal governance, but obviously we have a series of activities around the quality of data. So we are proposing a data quality and utility label to facilitate the identification of relevant data sets and helping researchers understand if indeed this or that data set will be relevant for the purpose that they intend to use it for. We are also developing a new infrastructure for the sections of our data, this health data that is mentioned above. And finally, we also have a series of activities to increase the capacity of member states, making sure that they are ready when the legislation comes into place. And ultimately, here you have an overview of what we aim to achieve really when it comes to citizens mentioned here, also benefiting healthcare professionals, making sure they have access to the data that they need to provide the care that they to provide, and ultimately making sure that when this data is reused, it is really to assist better policy making, more research, and also providing the single market that I mentioned here, really a more coherent system for the adoption of such solutions. As mentioned here, we do have this infrastructure in that we are proposing here, and health data access bodies are one of the key tenets of what we're proposing here. Why? They are the entry point, let's just say, for data holders. So that would be making data available once a permit is issued, but also data users, the entry point to which you would go to when you will be making a request. As you can see in the figure, these health data access bodies would be connected with each other, as well as with other relevant organizations, European agencies such as the European Medicine Agency or the ECDC, as well as European over what we call data sharing infrastructures. Think of some of the European research infrastructures that have been mentioned here, for example. And here, I think we just have an overview of what ultimately we're trying to achieve. So first, how can we help researcher to understand what data is available? One, the main goal we want is to have this European datasets catalog to just provide an overview of what data would be possibly available. So if it is not known, if it's not visible, the first step is to make this happen. Finally, it is formalizing how this access will be provided, so helping the researcher understand if this data could be used for their research. And once an application for accessing this data is made and a permit is issued, that is, if this application was approved, this is where data holders and these health data access bodies come into place by obviously issuing this permit when it comes to the health data access bodies, and then instructing data holders to make the data available to the user. And this access, as mentioned, would be made, this provision would be made in a secure processing environment where the tools and the compute power necessary for this analysis and processing would be enabled. And importantly, we want to make sure that when access to data is given, results are visible to the community as a whole, but importantly to patients to understand what has been done with their health data, which is why this last stage of publishing results and being as transparent as possible when it comes to why was this data made available and what was the outcome. So as mentioned here, we do have a legal proposal. This was submitted in May this year. It is currently being negotiated with the European Parliament and the European Council. But as you can imagine, we just cannot wait until the end of those negotiations, which is why we are already working on the implementation. And one of the key initiatives is the Health Data EU pilot project. So this is a pilot project which started last month. It is led by the Health Data Hub, so the data agencies of France, and involves, the type of partners that you would expect. Other data agencies, obviously, but also research infrastructure such as Elixir, BBMRI. We also have public health institutes such as HRIC. So as you can see, we try to bring together what we believe are the right people, the right expertise to bring their knowledge on the uses that we intend to facilitate, as well on the reality on the field. These are national agencies that already provide access to data. The idea is that how can we help them to make sure that this health data to you infrastructure really is fit for purpose. So we do have a 2 years project, 5 million for the consortium itself and 5 million for the supporting services that will be developed by the European Commission. I think, for example, this European datasets catalog that I mentioned here, as well as anything enabling the infrastructure to work. So the idea is that really this pilot will bring, if not an embryo, an initial infrastructure that could then be scaled up, plus a set of recommendations to member states as to how should this infrastructure look like when it ought to be deployed once the regulation is implemented. Very interestingly is that this will be validated through 5 use cases, and this is where we have the participation of many of our researchers. And this is also, I think, the way we can also ensure this complementarity with other initiatives by not only involving partners that have a foot in both initiatives, as well as understanding the landscape and how can they really complement with other initiatives. And that's it for me.
Thank you very much, Jerome. Quite in time. Thank you. Now, next speaker is Saila Rines, Head of eHealth and Aging Policy at DG Connect. Saila, I would like to have you on screen. Can you hear us?
can hear you. Can you hear me?
Yes, absolutely. Thank you very much for joining.
Very good.
So you have 2 minutes, as I said. I will give a bit warning, kind warning in 2 minutes left. Is that okay with you, Saila?
Yes, that's perfect. Thank you very much.
Thank you. The floor is yours, please.
Thank you. So do you see my slides?
Yes. Yes, wizard. Go.
Excellent. So good morning also from Luxembourg and DG Connect. I work in the eHealth Wellbeing and Aging unit of Connect, and when we talk about the topics of today, it has to be said and emphasized that we are constantly working together with Jerome and other colleagues in Sante Digital Health Unit, and with RTD colleagues, we work constantly together. So it's not that we are sort of proposing things in silos. On the contrary, we are really trying to ensure that there are complementarities and synergies between the different programs and initiatives that our DGs are bringing forward. My topic is about Digital Europe program and how it supports the data strategy and all the different data spaces. And we are now talking about the technological capacities. The idea for the Digital Europe program is to really accelerate the best use of digital technology. So we are talking about deployment of mature technologies. This is not a research program. It's to deploy and make available to companies, to researchers and individuals and everyone in Europe the computational and other capabilities so that we can also be autonomous within the EU and also foster the strategic autonomy in these technologies in Europe. The idea is to have these different capacities supported, such as high performance computing, artificial intelligence, cybersecurity, and importantly also advanced digital skills. These will be rolled out and supported by the European Digital Innovation Hubs that are about to be established in European regions. And the high impact deployments are really the use cases and needs coming from the field, such as in the field of health, which is one of the high impact deployment areas. And with this sort of structure, the idea is really to scale up the essential digital capacities in Europe. When we look at the structure from the point of view of data spaces, there are certain, like a number of data spaces identified in the work program of Digital Europe. One of them is health. There are again these different technological capacities and for example testing and experimentation facilities for AI that are feeding into all of these or offering their services for all of these data spaces. And there's also a data spaces support center which has just started. It's a coordination and support action of 14 million. It just started. It looks at the knowledge and, for example, template contracts and different processes that are needed to facilitate unlocking data within different sectors and also across sectors. We have also tools such as eID, e-delivery, e-translation that are developed to support the data spaces. We have AI on demand platform and cloud and edge services on offer. And then the infrastructure is federated when it comes to edge, cloud, and HPC. And there we have platforms, data centers, connectivity that go across these infrastructure components. And as I said, the skills and digital innovation hubs are very important. Also standards, interoperability and portability, and cybersecurity has its own program under digital, so it's also extremely important. Just a glimpse of what was funded in the first 2 years of Digital Europe program. So under artificial intelligence, data and cloud, there were 2 European federated infrastructures that we funded. One of them was on genomic data and another one on cancer imaging data, considering that cancer is one of the flagships and priorities of the current Commission. Cancer imaging project will start in January 23, and the genomics project started in September or October, just not long ago. Then there is a big testing and experimentation facility for health, which is going to be launched in January 23, 30 million funding from the EU and another 30 million from the consortium. And this step is expected to offer services also for like innovators so that they can go and test their solutions. Then we had other topics such as one on uptake on digital solutions and another one on building an ecosystem for digital twins in healthcare. These were coordination and support actions. And finally, a topic under the cybersecurity program to support also like SMEs and smaller entities in their cybersecurity resilience. Then I will just very briefly go through the cancer images project in principle. So this is about deployment of the infrastructure that we need to link and explore fragmented European data spaces of medical images. The project is also going to work on a business model, advanced tools and capacities, for example, in AI and HPC. And the ultimate aim is, of course, to have more precise and faster clinical decision-making, diagnostics, treatments, and predictive medicine. There's a lot more work going into this project that's not mentioned here, but just to give an overview. And for the genomics, it has also the sort of similar objective when it comes to building the infrastructure, to have like harmonized data resources and linked clinical, phenotypic, and other information so that they are securely findable and accessible across national borders. It's going to be a federated network where security and privacy by design will be ensured. So we are talking about data discovery, querying the data, and it really builds on the progress achieved and the agreements made within the 1+1,000,000 Genomes initiative of member states and a few other European countries. Here, as well as in the cancer imaging project, there is an expectation that the project will engage with patients, health professionals, and also will work on awareness raising. Okay, I have a. Can you still hear me?
Yes, absolutely.
Yes, because I have this problem with my computer. It goes off and on, but now it's back. Sorry.
No, we can hear you clear
Okay, good. So,
and see
yeah,
you
just
and think. Yeah, you have 2 minutes left. Just.
yes, and one slide. So
Good.
yeah. So just to highlight also like the principle or the underlying thinking we have in the digital program and in Connect, that we are sort of we are not catering just for one audience, let's say. So like in the case of genomics, we really want to cover both research and healthcare, and also to bring together the data and expertise. So these are the sort of the pillars that we have for all actions under digital when it comes to health. So this was all from me, and I guess I was a bit shorter than 10 minutes.
Really,
So happy to answer questions later on. Thank you very much.
really in time. Thank you very much, Christina.
Thank you.
So a small change in the plan because of some ailment in the next speaker. So we have to pass to the Q's and A's section for these two speakers first now. So I think we can show me the screen with, first of all, the online questions for you. We can come across, for example, Jerome, is Santé planning how to link with infrastructures?
Indeed, I mean, this is something. So we do have, let's put it that way, we do have several infrastructures. For most of them, they typically have a specific focus, be it on a type of data or a specific community. So we obviously are building on this expertise, on this knowledge. On the other hand, what we're proposing is much broader. So it provides the possibility to have other data sharing infrastructures to take part in the EHDS framework. So this is probably the way this link can be established indeed. Not only building on their expertise, involving them for that matter in the implementation phase, but as well creating a specific pathway for them to be part of the infrastructure.
Saila, could you please elaborate a bit on because in the end we do see the intention about aligning at high level, but the specificities of the linkage, so how to liaise with the plans, short-term, medium-term plans of Santé. How could you elaborate a bit? What are your thoughts about that?
Yes, indeed. As I said in the beginning, we are discussing with Santé all the time. We are really looking at what can Digital Europe program offer for EHDS, so that we are not, that the member states don't need to do some things which we have. For example, we are going to procure a middleware and we have the data support center. So we have the chance also, since they are to be launched, to influence also these, like what kind of tools and capacities would be most helpful for health sector and also for the EHDS pilots, not only for the infrastructures we are building under digital. But this takes time. Of course, EHDS is not, as a regulation, it's not yet finalized. We have the pilots. There is also a commitment to do a bit of funding also from Digital Euro program in the future to support the European health data space. So these are the synergies that we are currently discussing, and everything is really taking shape now. We don't have any, like, the actions are not yet there, but the discussions are ongoing. I hope I answered the question. Thank you.
So we do have in the room, while you put on screen online questions, Maria Luisa, please.
And this is Maria Luisa Lavitrano from the IOSC Association. Have you planned already how to connect with the different IOSC initiatives already ongoing through the project and through the IOSC Association initiatives?
So we are also discussing with colleagues in charge of EOSC, of course. So that this is part of the bigger picture and part of so that there are the connections that can be done via the EHDS. Of course, we also bring infrastructures into the EHDS. So that's one conversation we are having. And of course, EOSC is always there when it comes to, like, having the linkages of different infrastructures. Yes, of course. And as I said, we always have the angle of catering for research, but we are also have, like, from our point of view, we also have other stakeholders we want to support. Thank you.
And what about DG Santé?
So, I mean, obviously we did have discussions with the relevant unit in the GRTD overlooking your work. At the same time, obviously, we engage with the research world more widely by involving them in the consortium, we do have partners in common within EASC and our pilot. More widely, we also work very closely with the member state, with the national agencies already providing data to researchers. So we also try to make sure to take into account the reality in the member states, in addition to what is done within our research infrastructures or through our research project in RTD or what our colleagues in Connect are doing. So we have to bridge several initiatives. And sorry, you wanted to?
Yes, I have two questions, in fact, related to your presentation, Jérôme. Sorry? Yes, I'm Jacques Demotte from ECRIN. So I have two questions related to the EHDS regulation. The first one is related to the fact that when I read the draft, I was surprised to see in the listing of what is considered as electronic health record the research data, meaning the cohort data and the clinical trial data. So does this mean that in your mind the data sharing for cohort and clinical trial, the secondary use of research data for research purposes should go through the national health data access body, or is it possible to use research infrastructure to handle and to be able to share the data? Because these data are not strictly national data. They are, for instance, there are multinational cohort, there are multinational clinical trials, so there is no need to come back to the national nodes.
So thank you. So probably the first step is when we drafted the legal proposal, we try to be as broad as possible when it comes to the types of data that will be covered. We wanted to be ambitious, and we wanted to make sure that what we're proposing is relevant throughout. This is after regulations that will be applying for considerable amount of time. So that's why we didn't try to limit the scope as in itself. When it comes to the data that you're mentioning, we offer both possibilities. It is possible to use data sharing infrastructures. It is possible to have it done through national legislations. Now, as it is, the data holders that are contributing to this cohort that you're mentioning, by default, will need to comply with the law, will need to make this data known and available. What we're also foreseeing is that for cohort data such as yours, we are creating the possibility for, if a coordinator has the authority to provide access to this data on behalf of or take decisions on this data, to also be the entity to which the obligation that the rights of EHDS would apply. That is, they would make that available to the National Health Data Access Body on behalf of anybody who had contributed to this cohort. So it very much depends on the way the cohort is in itself structures, or the entity is part of the cohort or structure, really.
So we've talked a lot. Niklas Blomberg, Director of Elixir. Sorry for that. So we've talked a lot about the research. We haven't talked a lot about the innovation part of the Health Research and Innovation Cloud. And I think it'd be interesting to hear your views on that. It strikes me that, I mean, it's always sensitive to have private entities working on people's health data, but it's also an opportunity to create a sort of digital health industry in Europe. So it'd be interesting to hear your views on how the sort of research cloud can be used also for innovation purposes.
Sorry, I can talk about EHDS. When it comes to EHDS, a very good question. And indeed, one of the purposes for which data could be made available through EHDS is for the development of innovative solutions, product services, benefiting individuals. This is something that we are foreseeing. And in practice, we also want to make sure that any IP rights or privileged from companies are also not infringed as well. I want to make sure that when this data is made available, it's still it is not detrimental to private entities that are covered by the legislation.
Thank you, Jerome. May we go to the online questions again? It is to me there were
align with the CEF building blocks? Someone is asking. I don't know what CEF actually stands for.
Yes, yes, indeed. So because we are EID, e-translation, and others, these are the so-called CEF building. They used to be called CEF building blocks. So they are in there to help also with all possible applications, and the middleware is more for, like, for example, anonymization tools and other software, whatever is needed on top of what's already there as CEF building blocks.
Okay.
Thank you.
Thank you, Saila. Again, the questions from online. Again, for you, Jerome, I'm afraid, very popular today. The last step of the flowchart slide was reporting of results. As discussed in the first session, is the intention to provide feedback directly to the individuals whose data was used?
So as we have it in the legislation, it is more of a reporting of activities of the Health Access Body as a whole. So in terms of numbers of permits that have been issued, those that have been rejected as well, to understand if at times it wasn't made data was not made available, and on the results from the projects. At this stage, I think it will be very difficult to go down to individual level. Or at least we're not foreseeing. It doesn't mean that it could not be adopted by the Health Access Body, but we're not in the legislation.
But at the same time, my understanding of that is that there is a commitment on when a project is finalized, all the objects of the results of the output should be returned back, for example, enriching the data sets at origin, right? So have you, building on this, have you thought what could be the way forward? Because my understanding is in the pilot project is not a specific task on that, and I think is rather critical.
So this idea of including enriched data sets, so data set that would have been improved as part of the analysis that has with the data has been available. So when a specific permit has been issued, I think for us it is a way to just give back to contributing data holders and the community more widely. I think it will be a missed opportunity if what has been done within a specific access is not more widely shared and built upon, rather. And this is something we know other countries also looking into. I think this idea is also not to reinvent the wheel at each time. So that's why we include these specific provisions to benefit data holders and the community more widely.
Jack, please, a second.
Yes, I had another question because when I read the draft THDS, I read carefully the provision on anonymization. So the very good news is that the attempt to re-identify the data is prohibited by law. So this is very strong. The weak point is that there is no specific provision regarding the definition of anonymization. So it means that we keep the GDPR status, and in the GDPR, the definition of anonymization is not something that can be predicted, meaning that, for instance, if you go to the US, you can implement the HIPAA rule, and the procedure is something that is predictable. You know, if you perform this and this, you remove a certain number of items, then your data set can be shared. This is not the case with the GDPR, meaning that it's not possible to predict because the risk of re-identification is dependent on the nature of the data. And so we miss this some sort of predictable procedure that help to anonymize the data. So do you think that there is space for improvement here, or we will have to keep this situation that is very cumbersome, that result in very complex procedure as was presented, and also that result in a lot of cost, and who will pay for the cost related to the complexity of this legislation?
So when it comes to the EHS legislations, what was published is obviously what was proposed with the commissions. But as you could see it also has the inclusion of several implementing and delegating acts, which is where you would see the specific details on aspects such as what you mentioned on data anonymization, but on other aspects such as what exactly do we foresee as sequencing environments, what type of technical requirements, specificities we will be proposing. So there's only that much that could have been proposed or included in the proposal, which is why there'll be further work developed to just clarify all those aspects, to formalize those. And this is where you will see perhaps those details.
Thank you, Jerome. A lot of eagerness on the European Health Data Space. Let's welcome now Christina Kerikopoulos. Thank you for joining us as scientific advisor. No problem. No problem at all. Let me put the mic here.
Yes, please. Yes, please. Thank you. Yeah. So I want to thank you very much to the HealthyCloud coordinating team for inviting us. It is very important. Now I will take you to the research world and the European activities and the framework programs, but it's very much appreciated from us as policy officer to have a direct interaction with the health research community, because all the actions that we do and we design in the programs, it has to align with the state of the art, and this comes from all of you, part of this consortium. So just to make take the last 10 years, what has happened, and with the notion looking back to the future. So of course, big data. Everything started since 2010 or so. The last 10, 12 years, we have seen in the different calls of proposals in health research a lot of different, the effort to integrate data. Of course, we have asked that to integrate from different sources, clinical data, biological data, molecular data, public health research data. So all this, of course, the complexity of what we see in the big data world, it is reflected exactly in the discussions that you have in this consortium. And because, of course, we are talking about health, we are talking about humans. So everything is complex, and to solve diseases is very complex. And back, if I go, yes. Back in 2015, now, if I go back, we had a workshop again with the community, as we did for this consortium. And we brought again different initiatives. What does it mean, big data for health research? Big data for health research, it's not the same notion that we have for physics, of course, but it's high volume, high diversity, multi-source data, biological, clinical, environmental, lifestyle, data from large cohorts, new dynamic measurement and longitudinal approaches to data. So all of this is a complex system that one needs to operate. And of course, the first thing, if you want to collaborate across disciplines, because this was what very important in all the health research programs, we try to create this convergence between different disciplines. Clinical, basic researchers in the beginning, then IT and data scientists coming together in European infrastructures. Of course, then the bottom up, it is how we share data. Basically, all the challenges, they are coming around the discussion how we access data, how multinationally in Europe. This has been really the case, and the challenges in the different research consortia. And of course, in the European Union, in the research frameworks, since 2011, there were large efforts to support personalized medicine with a broad sense, from prevention, personalized prevention, to personalized therapy, but to new models in the healthcare system. And of course, the sense of personalized medicine is again the big data and the different diverse integrating of different sources, and of course IT and new AI, artificial intelligence tools. And of course, also at the European Union, since back 2016, we had set up very important and global initiatives for allowing funding bodies to collaborate together, fund innovative research in order to prepare us for the next and new and emerging epidemics. And that started already in 2016. And in the infectious diseases world, the discussion of sharing data, but of course epidemiological data and all, the need came already since then. Of course, in 2018, all the member states, they committed to, led by our colleagues in DG Connect, to the 1 Million Genomes Initiative. Of course, Europe is very strong in genomics research. Traditionally, we have very strong infrastructures. So there again, the same challenge is how we share data, how we access data, the different verification of data, and all of this is discussed in all these initiatives. And of course, we have the very important element in our framework programs, the European Strategic Forum of Research Infrastructures, where the member states are sitting. And since 2007, 2008, I think BBMRI and Elixir was one of the first infrastructures that were set for life sciences. But of course, after that, it became very essential for different biomedical research. And as you see in red, these are the health research infrastructures that are related to health data intensive research, and they are very essential in several European projects, and they facilitate a lot, particularly Elixir, Ecran, also the e-brains, the infrastructure for brain research. So different communities, the infrastructures and the facilitation of the different tools to allow this multidisciplinary research, at the core of which for modern biomedical research is the data again, has been supported very strongly. Here I want to give an example also. Since 2014, this relates to registries, patient registries on rare diseases. The Joint Research Center of the European Union has set up this platform, started to set up since 2014, a platform to have an interoperable way, semantic interoperable, fair way, with specific tools for pseudo-anonymization of patient data to support different clinical studies and registries, set up registries, different types of registries on rare disease research. And this took some time to be developed, but now, since last year, since the middle of this year, it has become really operational. There are very nice tools about pseudo-anonymization and how to securely share data. This, for the moment, it's registers for rare disease, and they correlate with the European reference networks. And no, this is a repetition. Okay, sorry, I'm going backward. Yes. And now I want to refer also to the Innovative Medicine Initiative. This was a very, very important alliance partnership between the public European Union and the EFPA, the European Pharmaceutical Federation Society of the Pharmaceutical Companies. And since 2010, again, around that area, a very important set of collaborative projects between industry, academicians, clinicians started. For example, a lot of them, they dealt with how to optimize, standardize, and be able to share electronic health records, or how we standardize the data, which data models in observational and pragmatic clinical trials and for research. So this was and of course also, I want to say, in 2018, we had the first pilot to set up the basis and the strategic thinking behind the European Open Science Cloud. And a lot of open access policies came into place. And that was around that 2016 and forward. And when I just want to clarify what we mean in health research, open access because it relates to personal data, we mean as open as possible, as restricted as necessary. This is the format that we are using in health research, and this is in our European consortium. And in this kind of back in 2018, in this kind of environment, with all these important initiatives in different data sources, we discussed with different consortia and of course in constant contact with the stakeholders here. We decided to have a workshop in March 2018 to discuss about the potential challenges and opportunities of establishing a health research and innovation cloud to be accessible by health researchers throughout Europe. So the analysis, of course, after that it came a position paper. And this position paper came from more than 50 representatives of 50 European collaborative projects, but also with a close collaboration with other DGs, DG Connect, with a lot of ICT and infrastructure contribution, Innovative Medicines Initiative, DG Santé about public health research. So these were the first, the observations and the needs what potentially could a health research and innovation cloud would support or would facilitate. If I see the verification and good practices and guidelines, of course, it is a very important element. Of course, also a very important element is the proper training of the next generation of medical researchers, but also data scientists, because health research has particularities. And in order to do this cross-disciplinary, which can bring breakthroughs, you need to have this kind of training on top of the data aspects training. And since then, of course, if we go here and we have the challenges that we identified after this workshop, a cold topic. And what we asked, what are the challenges that are identified by the community, is the need to make an EU research health fair ecosystem, fair measures. It's becoming more and more pressing by all these different communities, all these different diseases. And we need to integrate and to analyze this health data coming from different sources in order also not only to make sense of the data, but in order to bring the disciplines together to work, because it's essential for modern, for innovative health research. And of course, the security and privacy aspects, it was very much a discussion in all these fora. And then we come here to the winning project, the HealthyCloud, which took the task to follow on these recommendations, and of course, based on the novelties, on the more progress in different initiatives. And then if I go, and I will finish with this, of course, COVID came after, and then we had a lot of actions about the infectious disease and emerging epidemics preparedness. So, and the data sharing discussions, and that was a good platform in order to help the European Union to respond on that. And we supported a substantial amount of new projects, cohorts for COVID-19, longitudinal cohorts, diagnostics, therapies. I don't remember all of this, but also essential element to this project, it was sharing of data, of course. I don't say this is obvious, but I want to refer to you. This is a report that came out in March 2022 with a series of workshops that started in the second half of 2021 with all the European projects and infrastructures, European infrastructures that were involved in these projects. And what was the conclusion now at this moment? What is the need? Key recommendations. We still continue to need to improve and coordinate the implementation of FAIR, promote link between individual level data and metadata, again, support the enrichment of the different participant individual patients records data with more different types of data, and of course, develop ethical, responsive governance and guidelines. So basically, coming back to the future, we are coming again to the similar needs that the community needs. So, and I would like to thank for the consortium HealthyCloud for sharing the first draft of the strategic agenda. And I understand that there are so many needs in the health research community. And there is a need for open access. There is a need for specific low-hanging deliverables, like simple guidelines, fair guidelines for health research, depending, of course, on the different types of data. And I thought the European infrastructures, particularly the genomic evolution, has contributed and have delivered a lot of guidelines, but also this COVID-19 related collaborative projects have delivered, personalized medicine projects has delivered. But I think we need to make a synthesis of that, because as funders, I mean, simply the applicants, they are asking us when they make applications, simple as this: what are the standards? What are the guidelines? How we can follow FAIR principles, which has been a requirement and the principle behind the OSC already since 2018. Of course, the FAIR principles is something innovative, and the communities, by developing the state-of-the-art research and infrastructures, they are developing also the standards for verification. So I think there are some low-hanging fruits where the HealthyCloud could support, and I see a lot of importance. And the other thing, a lot of importance, how to tailor health research needs to open access whole vision of the OSC, but tailored for this specific community, because there are particularities and very important specificities. And of course, what I want to say, the European health data space has created a very important policy initiative, has created a lot of momentum. We have heard in different fora, the clinicians, the public health experts, epidemiologists, they were so excited about this. They are so excited. It's not still a law. They are continuously very excited. And we made a very strong effort. And I think Jerome also, who was working in RTD at that time, with my colleague Jana Makedonska and my head of unit, also Carmen Laplaza, that we made an effort to direct the state-of-the-art experience from the research world and the research infrastructures to these pilots for the secondary use of the European health data space. So several of you here, you are connected with this kind of pilots for the secondary use. So it is very important. Research has been the leading area in health research, where several of the challenges that are discussed in the European health data space have been debated, and solutions have been, some have been provided. So it is only natural that the research world will give a feedback in order to have a pragmatic development of the European health data space. And here I stop, and sorry.
Thank you. No, it's okay. Thank you very much. Very clear messages. Thank you. We may have just time for one question maybe in the room for Christina. There is one here. Irini, introduce yourself.
Hello, I'm Irini from Cienzano. Thank you very much for this very nice presentation. So basically in Cienzano, we lead the HRIC, Population Health Information Research Infrastructure project. And as you mentioned, there's a need for health research, there's a need for open data. So we have an idea of making available synthetic data.
Yes.
And I'm quite interested in the platform that you mentioned from the JRC that provides pseudonymized data on rare diseases. Is this, can you talk a bit more about this platform?
Perhaps I will send you a link later. There are some training workshops that are planned in December. What I know is there is a very nice pseudo-anonymization tools, which allows also to create virtual cohorts. So basically in different locations, of course, if the different clinicians, they register in this platform, of course, then you can identify and you can create virtual cohorts. And I guess the idea is to have also to support some federated learning in the future and artificial intelligence, because particularly for rare disease, the multinational dimension is essential to have the numbers that are needed of patients to make efficacy and safety assessments.
Thank you very much, Christina. I would like to only thank you, the three of our speakers today. Very clear messages, eager for the European health data space for secondary use. Thank you for the support of RTD and Connect to this initiative. A lot of opportunities are there, and we do have a plan, actually. Steve, you will talk about that plan later on in time. So now I think it's an announcement for a big applause.
Yep. So logistical announcement to facilitate the interactions derived from this number of participation. We will have the coffee break up to 12, but please be sharp at 12. So then we will have a presentation by Steve and then the closing discussion. So we will end up at 1 as initially planned. For the coffee break, we need to go downstairs, so where we have lunch yesterday. So the best is to follow Christine and our colleagues, so that we will be telling you how to get to the coffee. Thank you very much.
While they're busy drawing downstairs. Okay, so I'm going to start, I think. So for those who don't know me, my name is Steve Cannum. I work for HRIC, and along with several of my colleagues from HRIC, we've been responsible for putting together the draft strategic agenda. And this is a presentation of that agenda. I should apologize to those who were here yesterday because it's very similar to the presentation of the draft strategic agenda that I did yesterday as part of the AGM. So sorry. There are some differences, but not huge ones. So the plan of the session is to give some background and context, to talk about how we eventually reach some sort of consensus, the ideas for services that have been developed, go through those, some summary thoughts about where the agenda is and the HRIC is, and then some voting. Using a Mentimeter, we'd like to give some feedback from you and the people online about the views on the various services that have been suggested within HRIC. Okay. Genesis of the HealthyCloud project and HRIC comes back to the meeting that Christina mentioned and described earlier this morning, this 2018 seminal workshop that was held to discuss the possibilities and the objectives of a European Health Research and Innovation Cloud. One of the authors, Nicholas Blomberg, was here. He's disappeared, but he was here. So this was a key meeting with a very large number of people involved, and it talked about the creation of a Health Research and Innovation Cloud. It's worth pointing out at this time that although EOSC was in preparation phase, EHDS2 had not been discussed or even mentioned. So this was very much, these proposals were very much put as something building on EOSC. In fact, it explicitly says so. They came up with 5 recommendations, which again, Christina did list as well, but it's worth just having a quick look through them. Provide and foster standards, good practices and guidelines, certify infrastructures and services for a HRIC, an ethical and legal framework for a HRIC, establish a proper environment for training and fund public and private initiatives. Rather vague, necessarily so at this point, because it's just an initial attempt, but they're not different from the suggestions we currently got. The suggestions we currently got are in many ways built upon these early recommendations, as it happens, not deliberately, but they've turned out that way. That meeting led in turn to this 30 months CSA project, the HealthyCloud project. As Salva and Juan said, it's the E in the middle is the Spanish bit, but the 8 work packages, of which number 1's coordination, the rest are listed there, and then WP8. The aim is to produce a strategic agenda to advance the establishment of the European Health Research and Innovation Cloud. So that's where we come from, essentially. This is an overview of where we've been. We're at the red arrow. So we've gone through various discussions. We've produced a discussion paper. We've done some work on trying to build a consensus. We've now produced a draft strategic agenda, which hopefully some of you have been able to read. And the next stage is the stakeholder workshops, where this needs to be discussed further. This I put on because I like this graphic, basically, which took me hours to do, it must be said. But it's to stress the heterogeneity of the context that the HRIC has to work within. Huge mix of data types, data sources, data users, different terminologies, different ways of organizing data, different jurisdictions, regulations, languages, and all sorts of challenges. So it's a big, and as people have said all morning, really, it's a large and complex area. To try and make sense of that, and to, if you like, clarify the scope of the HRIC, we went through a 4-month process of creating a discussion paper to identify the issues that a HRIC should be addressing, in a sense to define the scope of the whole idea, the whole project. That resulted in these 6 main areas being identified. So, as I said, I'm sorry I was repeating from yesterday, but 2 key areas: legal uncertainties, which we've heard a bit more about this morning, and ethics and trust. And they are separate here because they were deemed to be important enough to be separate rather than a combined LC lump. 2 key areas around fair data, discovery metadata on the one hand, and interoperability on the other. Again, things which have been mentioned a lot this morning. And then technical infrastructures, key component, development of secure processing environments, etc. And then this underlying problem of sustainability. If you can, and in particular, how such services or such whatever is developed can be developed on at least semi-permanent basis rather than being a succession of short-term projects. Because this is one of the problems with all infrastructure programs within Europe at the moment. You can develop a system, and at the end of 3 years, you've then got to find a home for it, or it just disappears again. There was a all-hands meeting in February to discuss the findings of the discussion paper. 2 further areas were identified. One was how do you incentivize data sharing, and the other one was access governance. So that's where we were in the early part of this year. Some of this is, I'm going to whiz through this because it's been covered. But the problem, if you like, or the characteristic of this debate has been that, of course, the HRIC isn't operating in isolation. There is a lot of other stuff going on. And amongst the things going on is EOSC, which we've heard about earlier. And I'm sure most people are very familiar with EOSC, but essentially it's there to promote and support open science across all the domains in Europe. If you go, and lots of people are involved with EOSC-related projects. If you go to the EOSC portal, you can see that medical and health sciences are part of the scope of EOSC. There's no argument about that. If you click on that, medical and health sciences, you get a list of the currently available open science data resources. There's actually 28 listed. Well, there was 2 days ago, which is probably, I have to say, it's probably less than you'd expect, but this is in relatively early stages of the EOSC rollout. And it may be that this is a function of the difficulty of making sensitive data easily available. Not necessarily publicly available, but available. So there's EOSC. There is also, of course, as Jerome was saying, EHDS. And so you've got these two pillars of EHDS, which has come in more recently, but the one dealing with primary use, the support of not just free movement, but safe movement of people across borders by allowing primary reuse of health data for primary purposes, for treatment. But also Health Data EU, which is the secondary reuse pillar, and that is about the development of a whole ecosystem. It's the same diagram as Jerome was using, of structures, health data access bodies, SPEs, i.e. secure processing environments, various central services, infrastructures, whatever's required for safe and legally compliant management of reuse of data, health data. So and that obviously has huge implications as a resource of all sorts of types for health-related research going forward. So there's these two major infrastructure developments. And the issue has always been, throughout the debates we've had in WP8, where does the HRIC fit? As both EOSC and EHDS continue their development, where does HRIC fit in? Is there room for HRIC to sort of slide through the gap, or is that a realistic proposition at all? To add to the fun, we have these little explosions of new regulations and laws coming up every year or so. So there's the Data Governance Act, there's the Artificial Intelligence Act. There is nothing intelligent about artificial intelligence. It's one of the most poorly named things ever. The strategy for data. So there's a continuous sort of set of explosions of policies and regulations and laws coming through. Difficult. And this is just at the European level, the European plane. You could add to that a whole variety of, in another dimension if you like, a whole variety of national initiatives that are coming through, just to make life more interesting. Obviously they are linked to EHDS in particular, but they are coming through at different times with slightly different backgrounds, and it complicates the landscape enormously. You've also got global developments in standards, for instance. You've also got large numbers of projects being funded by Horizon Europe and others around. So this is a really complex, busy area. And it's partly because of that, actually, partly because of so much development, I think, that people are interested in the idea of a HRIC. A recurring debate, a recurring theme, has been, where would a HRIC stand in relation to EOSC and EHDS2? We're not sure where EOSC and EHDS2 stand in relation to each other, but which is another complicating factor. But initially, as I said, the HRIC was really envisaged as EOSC Health in many ways, as a sub-part of EOSC specializing in health. That was the original conception. But you could, and some people I've heard it said, that you could equally see HRIC as EHDS research and stick it the other way around. You could put it somewhere, use a HRIC as an interface between the two in some way. Yeah, one of the things that's come up this morning, I think, is this question about what is the interface going to be between EOSC and EHDS. Well, perhaps one way of constructing that interface, amongst other things, would be to produce a HRIC in the middle, facing both ways, Janus-like in the middle. Or it could be completely independent, somehow a separate body. Or it could be none of those, or a mixture of all of them. I mean, the structural parts of HRIC have not yet been clarified. We tried, this is just us, enjoying ourselves in Paris, having a workshop to try and clarify some of these sort of major issues, orientation issues, developing a consensus. And the consensus that we ended up with, I think it's reasonably fair to say, was that at the end of the day, we weren't that bothered about which part of EOSC or EHDS a HRIC would fit in. We were much more bothered about identifying the problems people had, the gaps and uncertainties they had, the concerns they had, sometimes concerns that things still weren't being tackled, even despite this sort of raft of large numbers of different initiatives and movements going on. Sometimes the gaps and concerns were because too many initiatives were happening and people were concerned about how they would interact and what the final shape of these things would be and what they would then have to deal with. So some of the needs there listed for better coordination, for specific support for sensitive data management, better guidance, provision of SBEs, good links to RIs, adequate training. These are all things that they came up in the original workshop to some extent, and they've come up again here. What the conclusion was, if we could identify the needs and gaps, acknowledging that there was ongoing work on most of them, people are aware of various initiatives tackling these things, but nevertheless they were perceived as remaining problems. Then if we could identify those gaps, then we could go on to specify the services that a HRIC could provide. And those 10 services are what's in the strategic agenda document as being the things a HRIC could provide. They don't form a coherent group in the sense that one doesn't feed into two, 3 doesn't feed into 4. They're quite a disparate group actually, but they could all have a HRIC label attached to them if that was felt to be a good idea. So those are the 10 services. I'll go through them in a bit more detail in a minute, but before that, any comments or questions about what I've said so far? Or are you stunned? Is that okay? All right, I'll carry on. I'm going to go through all 10. They fall into 5 more or less linked pairs, so I'll go through each of the 5 pairs. Now, at the end of the session, or towards the end of the session, we want to ask you to vote on these services. We want some feedback, and particularly for those, whoever's out there, and external people coming in. So we've set up a Mentimeter exercise at the end, and what we're going to ask you to do is to tick, if you like, or mark the 3 services that you think are the most important out of these 10. So and that's all. Nothing more complicated than that. So at the end, we will ask you we'll put up a list on the Mentimeter website and ask you to tick the 3 you think are important. And hopefully, we'll get the feedback on that fairly quickly, and we can feed it into the discussion as well. So pay attention, because you'll need to choose your 3 as we go through. So as I said, 5 more or less linked pairs of services have been proposed. The first 2 fall broadly into this monitoring and advocacy idea services. The first one is probably the simplest and cheapest of all of them, and the idea basically will be to rerun WP8 at periodic intervals. In other words, what we're saying is it would be a good idea to every so often, every 3 years or every time there's a World Cup or something, people would have a look around and discuss again what were their concerns, gaps that they saw, uncertainties and problems that they saw in health-related research, put that together into some sort of report using some sort of methodology and push it back to the other people involved, in particular the Commission as funders, but also EOSC and other infrastructures. So in other words, keep people informed. It's an advocacy function in the sense that it's taking in people's opinions and trying to push them to those with the money. So that's one idea, one service. You could, we were discussing earlier, you could make that a periodic project, but it might make more sense to make it a persistent infrastructure. The second one there, 3.6 it is in the document, is looking at a similar idea, but with a narrower scope. So, say within EOSC, although the same could apply within any organisation, it's really setting up a sort of special interest group, looking after the interests and, again, concerns of health-related research, particularly with regards to sensitive data. So this is a specialist group within EOSC in many ways, and lobbying for the inclusion of specific services where that was felt to be useful, feeding back to the EOSC structure in this case about problems or successes as well. I mean, it's a dialogue mechanism essentially. So those are the two simple services. The next two, something that's come up repeatedly today, the need for guidance on legal and regulatory issues. I mean, within a country, it is, I think, becoming increasingly possible for people to work out what the rules are. Not always easy, but at least they stand a chance. Even then, it's not always clear to them or anyone else that they are actually legally compliant, because the legal framework is still developing, so vague, and hasn't yet been tested to a large extent in courts. So there is a need, and particularly for multinational research, when the picture becomes very complex very quickly, because GDPR, as we all know, has not made for a level playing field. And we're not sure about what EHDS will do yet. There's a need for some guidance. And that, to be useful, has to be authoritative. It means it's got to be with people like the EDPB, the Data Protection Board, and perhaps, therefore, it needs to be done at a high enough level involving the whole of the health-related research community rather than isolated bits of it. Related to that is the fourth service there, which is a training service. Obviously, there's lots of training going on, lots of training materials being developed. But as, again, I think Christina was saying, what can you do with small amounts of money left over at the end of a grant project? Often it's very, very limited. So is there a call, is there a useful addition by producing a service which can focus, concentrate, centralize resources, expertise, generally as a training resource on a whole variety of areas, not just legal regulatory issues, but how to use a secure processing environment, how to apply a metadata schema, all sorts of whatever's required as things develop, essentially. So that's the fourth service. 5 and 6, or 4 and 5 in the paper, looking at promotion of fair data. Again, there is existing work going on this. There's plenty of EOS projects now looking at metadata standards, for instance. But these are both large, complex areas. And to be honest, particularly when you get into semantic interoperability, you're looking at decades of work. Would this be better done as an infrastructure service rather than a series of small-scale projects, which often overlap, it must be said? In terms of efficiency of member states' money, would it be better for some of this effort to go into a HRIC service rather than a series of projects? It's the question. So 2 there, one focused on metadata and findability, particularly across domains, and the second on interoperability, which is not just about data wrangling and reorganizing data, it's about the semantics and the categories and the terminologies used, which is the really tricky bit. 2 more services. This is back to the base idea of the HRIC, back to the discussions in the workshop. The idea of resources connected with health-related research being specifically grouped and organized, which can be done at 2 levels. It can be done as a catalog service. In other words, it's about identifying resources that already exist, characterizing them, describing them, putting them into a portal so that people can access them, etc., etc. And helping those resources also become more standardized as time goes on. Or you can take, if you like, the gold option, the more expensive option, and start to produce specific resources which don't already exist. Perhaps because you want to develop new techniques, new ways of using encryption or natural language processing or something, and they don't exist. Or perhaps because there is a genuine gap in a particular type of data, and there's a need to pull that together in a new repository. That obviously is the more expensive and more complex option, but my guess is that's what was closest to the original conception. But EOS Health has got broader. Not EOS Health, HRIC has got broader since. The final two. Both we've called these interface services. The first one is an interface with EHDS2 or Health Data EU, as we should call it, because the feeling, I think, is that there will be a need for an interface of some form. Exactly where it is, it remains unclear at the moment, but the research community needs to be able to talk to and make its views known to EHDS and vice versa. And it may be here that the existing RIs would be the obvious route, that between them they could form a structure which would act as the interface there. Finally, the last one is perhaps one of the most important, but also one of the most difficult, which is an interface from the research community to the public and press and politicians and everything else, non-scientists, if you like. Important because, of course, it doesn't take a lot for this whole idea and structure to come tumbling down if there are too many unfortunate incidents of data loss or misuse. And let's face it, there have been some big tech in particular are not to be trusted further than you can throw them, frankly. Google and Facebook or whatever, Metaverse or whatever they are, have their own agendas. And it's about gathering in data for training their algorithms. It's not about preserving the privacy of individuals. It doesn't take a lot for people to say, whoa, enough. Pull back, and the whole idea of data reuse could get seriously damaged if trust is not maintained. Which means there is a need to try and develop ways of explaining what's going on and trying to keep what's happening transparent enough for people to have some trust in the operations that's happening. Not easy. It's easy to say, not easy to do, but it may be an important service. So those are the HRIC services. The key question is who pays for it all? And the answer is we have no idea, basically. No money has been allocated to any of these, or the HRIC as a whole. At the moment, we're just talking about what might happen, what might be useful. We've had a lot of talk, hence the cloud. There are websites you can go to, you put in the text and it gives you a cloud back. It's quite fun. So, but basically, we don't know, and really we don't care. The gist of this is we are agnostic about who pays for it. It's whoever's willing to pay for it, to be honest. If EOS have got some funds and they want to push a particular service, great. If EHDS think this belongs to them and they want to push that service, equally great. We don't care. If B1MG do, or whoever, it's the umbrella and the branding is not important, the service is. It's our general view. Right. Somebody's phone linked in, I think. So essentially that's where we are. Relatively agnostic about things. Now that may mean that HRIC itself as an entity doesn't exist. The services may exist, and they all may have a label which says this is a HRIC service, but they may not. It's more about getting these services into play. Where are we? I think WP8 has been a checkpoint, really, this whole exercise. It's been an opportunity to look around and to discuss the further development and support of health-related research. We've identified these gaps and uncertainties. They are reassuringly similar to the ones in the workshop, and we have identified these services. and resources that would be useful to have, which again, reassuringly, are extensions and developments of the one in the original workshop. I think there's no doubt we have to be flexible about what we mean by a HRIC. The important thing is the services. So a HRIC might not appear at all, but let's get the services going. We need to broaden the discussion around what services and resources are required with more people, etc. But at the same time, if we're not going to just go around the same circles we've already been around, we need to keep it focused on the actual services and specifications that have been put forward, and produce more detailed descriptions of what might be possible or desirable, because the more detail is, the easier it is to cost them. And perhaps they should be prioritized as well. Who knows? I mentioned before, but in the next 4 months, there are 4 stakeholder workshops. The first one in just 3 weeks' time, I think, near enough. And so those are coming up. They will be obviously very important in trying to put some more flesh around these ideas, on these bones. And where next? So the original ideas for the HRIC agenda was to be an implementable roadmap for HRIC. Now, I don't think that's possible, because you can't implement anything if you don't have any money. You can't make any implementation decisions. So you either need some funds, or you need a robust business model, and we don't really have that either. I mean, essentially, business models in this area are really difficult because users won't pay for services, generally speaking. Certainly the people that put the data in won't pay for services, which leaves you either with European infrastructures or national governments paying for them. If you don't get that, you don't get the services. So the business model is quite easy, really. So we do need some sort of model, I would suggest, for sustainability. Otherwise, you don't get an infrastructure project. You get a series of small, short-term projects, which, as I say, I don't think is the most efficient way of doing it. It may be useful to set boundaries a bit. I think one of the problems we've had over the last year is that we've had insufficient boundaries on the discussion. So we've not quite known what's possible and what's not. Now, I can understand the reluctance of the Commission and the DGs to tell people what the rules are, what the boundaries are. I think it would be useful if they could tell people what's not possible. I mean, if someone said, look, you're not going to get a HRIC, forget about it. We'll might be able to fund some of these services if you make the case strongly enough, but you're not going to get another infrastructure into what is already a crowded place for infrastructures. That would be a useful point to make, I think. It would clarify stuff, particularly for the stakeholders going forward. And any other boundaries that come to mind would be useful to set. Let's try and clarify what is possible, what's not. Something that's not happened up to now, it might be worth thinking about, is can commercial companies be involved in this in any way? You know, the IHI initiatives are large-scale, well-financed work. There's a lot of stuff going on there. Eden was mentioned earlier on, for instance. Do they have a role in a HRIC? I don't know what the answer is, but I think it's a good question. The final date for the strategic agenda is August, but that means, as we were saying yesterday, that in fact most of the work has to be done by June, which means that this group and the stakeholders and everybody else has got 6 months of really quite intensive work to clarify this and get it down into a substantial document that can be then sent to the Commission, essentially. And that's it from me. Before we get into voting, what's that? 38 minutes, that's not too bad. Before we get into voting, any general points or discussion? But we can have them after we do the vote, otherwise. Gary, yeah.
Yes, thanks, Steve. Gary Saunders, Iatrus. Maybe when you're talking about setting boundaries, I think it's really important to say that in the generation of the strategic agenda, we've had a lot of feedback. So some of these services might be in EOSC, some of them might be visioned to be in EHDS. But what I think is nice is that we've not really had much feedback to say that we need services outside of this 10. So if you think about setting boundaries, then these 10 services, I think, are somewhere that we're really starting to solidify around. And we don't have that much time left in the project. So I would encourage us, and I'll be leading a lot of these workshops for the stakeholder engagement. It will be about getting feedback on these 10 services rather than broadening out. So I think that's quite important. If you're trying to set boundaries, maybe we concentrate on these services that we have here.
I would agree 100%. Yeah. I mean, I think it may be that 3 of them might fall out, and people will say, well, we don't really need these at the moment. These not, and these. But what we don't want is 11 and 12 and 13 to start, considering those. Was it Mihaela at the back? Yeah.
So, Steve, regarding your question, how to focus the discussion better from a legal perspective, I mean, concerning the legal services, I think it's important to look at the models that we want to adopt, because the legal services depends to a great extent on the legal model, business model that we adopt. Yeah. So without that, we'll end up with the same discussions that we had in other projects, meaning what is the regulatory framework in that and that country? How can we do it in order to comply with the national legislation? So we have produced a lot of guidance, model agreements, etc., transfer agreements. So my concern is that if we do the same thing in the context of this project, we might not improve the situation. So can we set the boundaries in this respect, meaning to look at the model, not business model, but what kind of model we want to adopt in order to better focus the legal discussion?
So do you mean in terms of the services to be provided by?
Absolutely, yeah.
So we're not looking at a legal office that people can phone up and say, what do I do in this case? Yeah. It's more a set of resources that people can use.
Exactly. Yeah. And then maybe we should look at the connection between this and the European health data space and take it from there.
Yeah. I think actually there's a broader issue, because if you're going to say to folks here, make use of these legal services, and have some sort of business model involved, that may be that in the original grants from the funders, there has to be some funds to make use of that. And extending that, there should be funds for people to de-identify data, for example, and to whatever additional work is required on consent forms, etc. Otherwise, people, I mean, it's happened to us working with people. People get to the end of a study. We say, can we have the data? They say, well, yeah, but we don't have any resources to de-identify it. We're not sure how we do it, where we go, where to put it. All sorts of issues come up. And these things really need to be put in at the beginning and properly funded. So it's not so much management of big data, it's the management of small data that needs to be sorted. Niklas.
So just looking at that list and reflecting on some of the talks this morning, I think we start to see quite a nice sort of interface with the various high-level initiatives. So one of the things I've taken away from the talks by the colleagues from the Commission is really, so I see a very strong high-level similarity between the genomics data infrastructure that we are driving in within Elixir and, in a way, the European health data space. So in the 1 million genomes or the genomics data infrastructure, I think the really significant part of that, apart from the technical work, is the sort of strong ministry level backing for making this personal data available for research purposes with the explicit aim of improving future health and care in Europe. And if you look at the European health data space, especially the second work pillar that Jeroen was talking about earlier, it is very much the same thing. It's a very strong sort of ministry level backing for making very sensitive data available for advanced medical research. If we look at your list here, I think I see a lot of items that I think fit very naturally into the EOSC structures that Maria Luisa was elaborating on earlier today. I mean, the metadata, data interoperability is really part of the core of EOSC, working with communities to codify that, training and people development and so on. I think that the space I see in the middle, which is really unfilled and I think is very critical, is to say that we get this data out of these national data resources and available for sort of advanced analytics, artificial intelligence, digital twins. That requires secure collaborative environments with actually quite a lot of compute and storage power on the level that is only provided by some significant national centers or the European HPC centers. There's not many places you can go and get, say, a couple of 100,000 cores of GPUs to run deep learning algorithms. And I think that's really where we can. It doesn't necessarily require a new organization, but it does require some concerted thinking and sort of collaboration across the communities to make that possible within the European sort of structure. But if we can get that working, so that there are ways of making data available for advanced research in these environments, I think we can really propel sort of European research. And that doesn't compete with federated learning approaches, but I think there will be things where the amount of compute power really exceeds what local centers can provide.
Yeah, I think that's true. I mean, I have a certain level of skepticism about the use of big data, because I suppose because at the end of the day, I think you still got to go down for the double-blind clinical trial to randomized clinical trial to actually get the firm evidence of causation. I think there's a tendency to use mining and collation, perhaps to get too enthusiastic about what it's capable of, but it obviously has a contribution, and all these parts have different contributions to make. And you're right, the compute ability will be critical. But of course, then you also raise the issue of cross-national transfers of data, and all the complexities that brings. Can we ask you to vote? Oh, sorry, Christina.
Yes, thank you very much. I just want, something I'd say it's not so visionary, just one comment that I come back to the discussion of that genome paper and the workshop and the different examples that I gave from the COVID-19 infectious diseases community. There is an absolute need for the community that they are not working in their daily business with data scientists and clinicians or data sharing, but there are communities that they are start now to create. They are in the infancy of start creating, sharing data, not in a large scale yet, but or smaller regions, researchers in smaller hospitals. So the idea of having kind of some guidelines for fair data or guidelines for or examples of how to do the legal and ethics guidelines. I mean, we have so many projects. That was the idea when we brought them together. If someone just goes and analyzes data and makes a map, like a pathway. If you are working with genomic data, this is the best practice. If you're working with public health data, this is some good practices. Fair guidelines. This was one idea of the HealthyCloud, to come with some tangible guidelines on that aspects. Well, and I was wondering if that could be a good focus for the next tangible focus for the next period of the project as a first reaction, and then I can say the view.
I think one of the working groups practices specifically looking
and then I can mention something. There also, the community needs a lot. There is a need for multidisciplinary research and basic and clinical research and IT and AI and data scientists and IT technologies. So there is a lot of training produced by projects, by European infrastructures, e-training, webinars. I mean, we could imagine like...
There needs to be the money.
No?
There needs to be. We were talking about this yesterday.
E-training.
There is a need for
yes.
technical skills and training. There's a need for data management skills, but they have to be paid because we can't recruit those people.
And also the cloud idea, which was inspired by the OSC idea at that time, it is also open access. The resources that one can find in health research, where like a portal where you can find public information. It's not only to do a closed collaboration in a consortium, but it's also the other dimension of being available to a broad community of researchers and enable innovation with state-of-the-art approaches. So it's also the rest of the community and the open access, real open access.
But I say again, what I think the funders need to be aware of is that the expertise that's required to properly, at a technical level and at a sort of data management level, costs money that simply isn't there in the system at the moment.
But
we can't recruit staff to do a lot of these projects.
No, but I thought we have a lot of European thematic projects that they are doing that with the European infrastructures, with other infrastructures, innovative medicines initiative. We have some outcomes, deliverables that could create. One could create a synthesis and create a consensus guidelines that the funders could use and other new projects could use.
Okay, thanks.
Thank you.
Thank you. Can we have a vote? And then can we carry on discussing afterwards?
Okay.
We need to get the data in if we can. So, jolly good. Vote away, please. Ooh, that's a percentage. Yeah. So people have been voting, yeah? Good. Not yet. Please vote. Your big chance. Thank you, whoever said that. Yes. The absolute numbers must be quite small because they're changing quite quickly. Oop. 29, yeah. $31 going up. Any more for any more? We're stuck on 31 at the moment. Do I hear any more in the room? You're only allowed 3, by the way. No cheating. Anyone who does more than 3, we will find out who you are. And we will kill you. But apart from that, yes. 32. Any more for any more? Cheers, Nicholas. A few more minutes. Anyone still voting in the room? Dun, dun, dun. Whoop, 33. 34. This, I think, is already looking very, very interesting. Perhaps you could do this at the end of each stakeholder meeting and have a similar exercise, collect more votes. Yes. The interesting differences between the meetings. Yeah. Yes, I was waiting. Well, I got 35. I don't think there's any more. So, okay. Not in any particular order, because I think this is the most interesting thing for me, is that the lowest at 4% is 8, which is an EOSC health service resource. So that was, I think, the closest to the original conception of HRIC. I would say that's what people meant. And next to it is the health catalogue service. They're 4 and 5%. I know it's a small sample, but 4 and 5%, the smallest, which is really quite interesting. The highest, 17%, is a data interoperability service. And I think that says a large amount about what people are actually worried about or spending money on time and effort. And then 13% is the metadata standard service. So going through them, we got the monitoring service, this idea of a periodic WP8, if you like, is 11%. A legal regulatory guidance service, 15, so that's the second highest. Again, where people's concerns are. Training service, 11%, pretty reasonable. Metadata standards, as I say, 13. 18% is the highest. Data interoperability service. Then an EOSC sensitive data sensitive data user service, not for sensitive users, but for sensitive data, at 6. And this is also 6, but it's at a different height. So presumably 5 and a bit. Is the EOSC health catalogue service, and then the lowest one, health resource service, which is fascinating. 13% is the community service interface, between the research community and EHDS, Health Data EU. There's a healthy score, 13%. And then the last one, 4%, also the equal bottom, a research community interface service with the general public, which I think is also interesting, because personally I think that's really important, but it's just really difficult. But so I think that's really quite useful. Thank you very much, all those who voted. Sorry? Oh, sorry, there's one more question. Yes, we'd like to know a bit about you for our files. We'd just like to know what sort of person you are. Yes. Are you a representative of a patient or associate or organization, an ethical or legal expert? Do you have a data management role? Are you a researcher, technical expert, policymaker or funder, project manager or admin or other? You have one vote on this, not 3, just one vote, please. Yeah.
They need to tell us what it is to put it in the category.
Steve, if you allow me, a quick looking at this, maybe for the future stakeholder forum, we should look at which ones are underrepresented, also to ensure that people are.
Have a chat with Gary, yeah.
For example, the fact that the service on interfacing with the general public was low is because here we don't have representatives of the general public. We don't have citizens, we don't have patients, which is something that we should take into account for the...
Do we need to... We are members of the general public as well.
Yes, but as researchers, we are interfacing in different ways, I think.
Yeah, but I think, to be honest, I think this is an area where researchers have to take the lead. But you know, I think it's a problem. Yeah. Jack.
No, I just wanted to say about that it's important for the research and policy makers community that the trust of the public is something very central, meaning that I know that there are some countries who are very concerned. For instance, the Scandinavian countries are very concerned about the trust of the public in a, so with regard with the repository. So I think it's important. Yeah. I wanted to make another point related to the 10 services. I think the first one, the which is about the monitoring, is something very important. But I think it could go beyond just monitoring, and it could go also to the establishment of funding recommendation, a bit like the cancer mission, meaning there is a board, and the board make recommendation in terms of funding, and this mentoring activity could be could have the objective of establishing a link between the EHDS and the EOSC, and could make recommendation on what are the next bricks to be funded to really establish the building, the right architect for this building.
So that's a sort of model that could be followed in this context as well. Yeah. So we've got 36 people who've actually said who they are. So gone one up. So yes, as you'd expect, mostly researchers and project managers, admins, data management role. Thank you very much. Useful data and something to take forward and hopefully, as we say, added to in the stakeholder meetings as well. Interesting. Thanks for Mariola as well for doing the Mentimeter. Thank you very much. Any other comments? We're approaching 1 o'clock. I don't want to put any pressure, but any other any other comments? What's that?
Yeah, maybe just briefly to reflect on what Christina said about the need for guidelines and recommendations. So if I think about these services, even though they have a particular name related to fair data or related to interoperability, I think underlying that service is the need for that service to provide exactly that. So even I would say at the meta level that they all provide recommendations of how to interact with EOSC or the European Health Data Space, but the actual service itself would be a toolkit for recommendations or training or something else related to that topic.
Yeah.
So even though it's slightly differently named, I think there is a lot of alignment with what your plans would be.
Yeah, this is very much the 10,000 feet or the 3,000 meter view, rather than getting into the details of any particular, scope, any particular project. Yeah. Okay. Thank you very much.
Thank you.
And the best of luck.
Closing there.
Yep.
Time to close. Time to close today.
So it's time to come to a close. So, and when you organize an event, we have been these 2 very intensive days. I would like to start saying thank you to Christina and to Mariola and to the people who has made possible this event. Thank you very much. It's been a lot of work outside home,
Exactly.
which is
So this
even more complicated.
Yeah, this remote organization plus the hybrid format, so that means huge effort. So we really appreciate the work they have been doing, and we really appreciate your participation here and also your participation at home. And okay, thank you very much to all our speakers here, there. Thank you very much for all the inputs you are giving to us, because to shape this strategic agenda, the roadmap, all the outcomes of this project, and the engagement we want to put in place with the stakeholders involved. All the discussions that have been taking place yesterday and today are crucial to make this project a success. Okay, let's give my honest thanks to you again.
So, and just to go a little bit forward, the work that we have shown the last two days has been the work of 18 months. A lot of work, a lot of meeting, a lot of discussion, and we have 6 months ahead. Thank you for removing 2 months for the calendar. So we have 6 months ahead, very interesting, where we like to refine what we have. So we have a starting point that is a draft strategic agenda, and we expect your participation, your active participation, not just from the consortium, but from the many stakeholders that we are going to be talking with, including the Commission.
Yep.
We want your guidance. We want to explore those boundaries, where we shouldn't be considering, where we have an open landscape. Please let us know that place is not for you. So don't tell us where to go, but at least tell us where not to go.
The negative way.
Thank you.
Okay.
But
thank you.
Thank you. Just to mention that, first of all, I said how much we appreciate all the colleagues working in RTD the HealthyCloud is funded by the Research and Innovation Program. This interaction and the latest developments in this dynamic collaboration with the community that we have. This is really fantastic. And what I wanted to say also, congratulations for the first draft of the strategic agenda, because it is like, you know, it is a pragmatic description of the landscape and of the different challenges, but this is the inherent challenge and complexity of health research. And of course, you would come with this kind of broad aspects, challenges. And we have a lot of opportunities, you know, in the health research infrastructures work program. It's not the health research program where I'm working, but the health infrastructure work program, they are going to come out pre-publications of the proposals and the calls for 2023-24. They are coming out today, actually.
Today? Okay.
Or today or tomorrow, maybe they are already out. So you can see the infrastructure work program has really evolved to support EOSC, all the concepts of EOSC. But the thing is, health research is in between. You know, if you want to do advanced and innovative research, you need to bridge the worlds of health research and the healthcare, and it's always this kind of the dynamic of this interaction. And so there can be opportunities, I think. And if you see also the health research program, there are also a lot of data-intensive, of course, efforts. But as a low-hanging fruit, I think the community keeps asking for some guidelines, actually.
So that's, we're taking note of this.
Yes, sorry for repeating it.
No, we take note of the guidelines by your side, and we will do our best, or providing and delivering. So we can close here. Thank you very much for your participation here and online. And happy to see you soon.
See you soon. Safe trip home.